So does anybody have any questions or anything we want to review before we start tonight's lecture? I emailed out the slides to tonight's lecture only about 10 minutes ago, so I apologize. I completely forgot to send them out earlier, but you should have them in your email by now. And AK-47 is a Russian. Ours is an AR-15. So actually, it's an M16, but the civilian version is an AR-15, I believe it is.
AR-15 is a semi-automatic. The M16s is fully automatic. They use in the military.
Okay, so does anybody have any questions, anything they want to go over before we start tonight? Everybody's good? Okay. So tonight we're going to do chapter 7, which is really kind of I'll put it all together of everything we've been talking about so far. So it's probably not a lot of new information. Maybe we'll just explain it a little clearer, a little better, and we have time to ask questions and everything like that. We really have 2 nights. We have tonight and tomorrow night. So I don't think we'll need the full 2 nights, probably just maybe a tiny little bit tomorrow. And then we could decide either to get ahead or do some review. And then also we have to decide if we want to do some review Motzei Shabbos that would be unofficial. You know, in other words, not, I shouldn't say unofficial, but it's not mandatory. So if people can't attend, they don't have to attend. But if somebody, you know, wants to just chime in, you know, for say an hour or so, we can go over anything and everything that anybody has any questions about. Okay, so between tonight and tomorrow evening, we just have to decide about Motzei Shabbos and see if that's something we want to do and what time we would want to start. Okay, so chapter 7, we're going to talk about pathophysiology. So physiology was the function of the body. Remember, we just did anatomy and physiology. So anatomy is the structure of the body. Physiology is how the body works, the function of it, how it actually does stuff. Pathophysiology is disease to the body or problems with the functioning of the body. So we're going to, this is going to start being now more towards the medical part, the emergencies part that we're going to go through. And we're going to go through every body system, and talk about whether it be cardiac emergencies or respiratory emergencies or neurologic emergencies, dealing with the brain and stuff like that. So we're going to go through every section. Everybody can see the slides on the screen, I would assume. Nobody said they can't see them or anything like, you can't see them?
Nothing on the screen yet.
Oh, nothing on the screen. Oh, so it's good that I asked. Okay, hold on. Let's find.
I can see your face, but not the slides.
Okay, give me 1 second. It was there when I checked before, but obviously it disappeared. Okay. So you should see something saying this. Oh, it went right to the end. Hold on.
Yeah, we see it now.
Yep. Okay. So we're going to talk about, again, the very basics of the body all the way through disease. So that's what we're basically looking at tonight. Let me just arrange everything so I could see if somebody else is trying to get in. Okay. So we said that the cell is basically the power plant of the body, and there's millions and millions and millions of cells in the body. They're microscopic. You can't see them with the naked eye, right? We need a microscope to be able to see them. And even though they're tiny, tiny, the size smaller than a pinhead, they have a lot of structures inside of them. And basically the purpose of the cell is to generate energy. So, and a cell will generate energy by taking in fuel. And we said already the fuel of the body is oxygen and sugar, right? And when the cell has oxygen and sugar, it will burn it, okay, and make energy. And when a cell makes energy or burns the fuel, it's called metabolism. And then we had 2 types of metabolism. We had aerobic, with oxygen, and anaerobic, which is without oxygen. And I'm going to show you all that, in a second and stuff. Okay. Now, we have to understand that a cell is like a very complex thing. Just like the body is a very complex thing, your cells are very complex also. So a cell is contained inside a wall, and that's called the cell membrane, right? So a membrane is a wall around it. And just like the blood vessels have the ability, the capillaries have the ability to let things in and out, like let the sugar in and the oxygen in and out, stuff like that. The cell membrane has the ability, because obviously we said that the cell membrane needs oxygen and sugar. So it has to have this membrane around it that's capable of letting things in and out. And the term for a wall whether it be the wall of a blood vessel or the wall of a cell, letting things in and out is called permeable, right? So something that's semi-permeable means that it lets certain things in and it doesn't let other things out, right? Something was totally permeable, it would let everything in. So the cells basically have the ability to let certain things in on their own. Sometimes they need things to carry them in. And we already learned an example of how sometimes a cell needs something else to carry it in. When we talked about oxygen, we said that on the red blood cell, there was a substance called hemoglobin, and that's the substance that the oxygen jumps on board, okay? And that's the only substance that could bring oxygen into a cell. So if somebody had plenty of oxygen in their body because they were breathing fine, but they did not have enough hemoglobin, their cells would die because the cells wouldn't let the oxygen in without the hemoglobin. And the same thing holds true for sugar. It needs insulin, right? You've all heard insulin with diabetics, right? A cell needs insulin to let sugar into the cell. The only cell in the body that doesn't need insulin is the brain, but every other cell of the body needs insulin to let sugar in, okay? Now, the other thing that we just have to talk about briefly is that stuff goes from an area of high concentration to an area of low concentration. Everything in your body, it always works that it goes from high concentration to low concentration, pretty much, right? So what's going to happen is if inside the cell, the sugar is low because it used it up, and outside the cell, the sugar is high, it's going to cross across this wall. That's what they're trying to show you here. They're showing you with salt. So picture this is the wall around the cell, right? Not this. This is not. This is just a cup of water, right? And they put a membrane that's semi-permeable. So they put like a what would be a good way to describe a membrane? They put like a sheet of paper. They had the ability to let things go through it, okay? And this thing that we're looking at down the center here is really this wall of the cell, or it could be the wall of a blood vessel. It doesn't matter, right? It's something that's semi-permeable. So what they're showing you here is that on one side of this semi-permeable membrane, there's a lot of salt water. On the other side, there's fresh water with very little salt. So what will naturally happen is that the salt will cross over to the fresh water and turn it into salt water until it's equal. So let's say there's 5,000 parts of salt in here and 0 parts of salt in here. What will happen if it's truly a semi-permeable membrane is there'll be 2,500 parts of salt in here and then 2,500 parts of salt in here, and it'll equalize itself. And that's how the body brings things in and out, right? Now, sometimes these membranes get diseased and they become more permeable. And we're going to talk about things where you'll see, like, oh, you've seen it. So you get a burn, right? You get a burn on your skin. And what happens? You get a blister on your skin, right? So I don't know how you say blister in Yiddish, but you get a blister. So what's trapped under the skin when there's a blister? It's plasma that's leaked out of a blood vessel. So what happened is that the wall of the blood vessel was traumatized, was hurt by the heat of the burn. And it leaked plasma out, and the plasma got stuck under the skin. So you see that bump of fluid. So that's an example where the semi-permeable membrane, which was the wall of the capillary, was traumatized by the burn, by the heat, and now it's becoming more permeable and it's leaking out. You've got blisters on your feet, right? When you wear shoes that were not right, and you get that same, pocket of fluid trapped under your skin. So in that situation, the cell was damaged by the rubbing, and the blood vessel, the capillary was damaged by the rubbing, and that's how it came through. So that's what they're kind of talking about here. And as we go on, it'll make a little more sense. But what we have to take away from what we talked about so far is that our body is made up of millions and millions and billions of cells, right? And every one of those cells is a living thing, okay? And its purpose is to make energy. So when you talk about a heart, let's just say, well, we know the purpose of the heart is to pump blood. Well, all the heart is again, thousands and thousands and thousands of cardiac cells, right? Myocardial cells, heart cells, okay, whose purpose is to make a heart, right? So all those cells join together and they create a heart whose function is to pump. Now, obviously for a muscle, the heart is really just a muscle. For the muscle to squeeze and pump out blood, it has to have energy. And that's the sugar and that's the glucose that the cell burns to make energy, right? So that's what basically happens there. Okay, so let me just fix the thing here. Oh, very good. Somebody asked a good question. Is semi-permeable similar to the term porous? So I don't know if anybody can translate any of this into Yiddish so people understand it better. If they don't understand the English part, I feel free. But when something's porous, it means that fluid can go through it, right? So yes and no. I mean, it is porous, but it's porous to a point. In other words, it controls what it lets in and out. It doesn't just, like your capillaries don't just let things leak out all day long. It only lets things leak out that need to leak out. So that's what I was kind of saying here, is that if this was the cell the wall of a capillary. Okay, and this is, say, your cell, and this is your blood vessel. It's only going to let sugar and oxygen cross over into the cell on this side if the cell needs it. If the cell doesn't need it, it's not going to let it over. And the way it decides if it needs it, it looks at the amount of it. So it's going to measure, the body's going to measure the amount of oxygen and sugar in this cell. And if it's low, it's going to allow the sugar and the oxygen to cross over. I know they're saying salt here, but that's just an example. Okay, because we do need other things. We need things, you know, a lot of other things in the body. Salt is considered what's called an electrolyte. So we need certain things, salt, potassium, calcium, right? All these things in the body to make muscles work, to make the body work. So it's not just oxygen and sugar, but, you know, on our EMT level, we don't get into it. So I know you think we get into it crazy, but we don't get into so crazy. Okay, so there's a lot of other things that the people need. Now, you've probably had the situation when one of your kids had a stomach virus and they were vomiting and they had diarrhea, right? And so fluid is leaving their body because they're vomiting and they have diarrhea. Within that fluid, right, it's not just water. So in that fluid are those electrolytes, are those sodium, potassium, and that stuff, which is why your doctor doesn't tell you to give the kid a bottle of water to drink. They tell you to give them Pedialyte, right? So in Pedialyte is the electrolytes, besides the fluid, is the Pedialytes that the child is missing because they're throwing up. If you were just to give a kid who was dehydrated from vomiting water, you'd actually make them in worse shape somewhat, because what happens is if their levels of potassium and sodium in their body are already low because they've lost so much from vomiting, and you give them water that doesn't have anything in it, you're going to lower the level of potassium and sodium that's left in the body. So, you know, we'll talk about all this stuff as, you know, as we get into, you know, into class more and more. But, you know, the body's very complex. So you have to always, anything you do, you have to weigh what's the consequence, what's the bad thing that could happen because I'm doing this, what I think is a good thing to the person. Okay, so we said that certain substances need to be carried through that wall of the cell, okay, to make the cell work. And a lot of times they have to be carried by another thing in. So on our level, we talk about two things that carry other things in. So we said insulin, okay, which is a hormone produced by the pancreas, okay, is the only way that sugar can get into a cell. And I said last week that the sugar gets into the bloodstream. How? Like, how do we get sugar into our bloodstream? So remember, our bloodstream is one part, that's the transport mechanism. And then our cells, the blood brings the sugar and the oxygen to the cells via capillaries, right? So this hormone insulin, right, which is produced by the pancreas, what happens is that when you eat food, okay, so you had a nice dinner before we had class, hopefully, and your body, your digestive tract, your stomach and your intestines, different enzymes in there start to break down that food and draw out all the good stuff from it. Okay, so that's what basically your digestive system is. It's kind of like a recycling. It takes all the good stuff out of the food and it brings it into the bloodstream. So that's not insulin doing that. That's just your digestive enzymes doing it, right? The things that are inside your stomach and your intestine, the different juices that are in there that do that. Once it's in your bloodstream, for that sugar to get into the cell, it has to find an insulin molecule, a little drop of insulin, and jump on board it. If not, the wall of this cell, okay, let me just go over here for a second. The wall of this cell, right, has a door that only insulin can travel through to bring sugar in. So, I mean, it's not, it's hypothetical door. It's not like a real door. But in other words, the only way that sugar can get into this cell is if insulin is carrying it in. And that's also true with oxygen. The only way oxygen can get into a cell, okay, is if hemoglobin carries it in. So the only two terms we need to know for the test as far as bringing things, the good things into the cell, because the only two good things we're concerned about on an EMT level is sugar and oxygen. So we need to know how does that sugar and oxygen get it into the cell. So glucose is carried in by insulin and oxygen is carried in by hemoglobin. Now, this is why, yes, insulin, somebody asked a question, does insulin travel through the bloodstream? Yes. In other words, everything that gets to a cell is carried by the bloodstream, okay? So if there's sugar in the blood, yes, absolutely, there could be sugar in the blood without insulin, but there has to be insulin and sugar for that insulin to leave the blood and get into the cell. So that's the problem a diabetic has, right? A diabetic doesn't produce insulin. So they can eat all the food they want. They can get all the sugar they want into their bloodstream, but it's not going to get into the cells. So having sugar in your bloodstream is not good enough. You have to get the sugar into the cells so the cells can make energy, or else you die. The same thing, you could be breathing perfectly. If you don't have enough hemoglobin, then it's not going to get into the cells. So your cells will die. Even though your blood has oxygen, your cells don't have oxygen. So you have to kind of think of it as the blood is just the pipeline, the transport mechanism to get all these good things to the cells. And then the cells need other things to carry them in. Now, there's certain things the cells will let in on their own. So salt will let in on its own, potassium will let in its own. So you eat a banana and you get potassium into your bloodstream from the banana, okay, that's going to travel into the cell pretty much on its own. But it just happens that glucose and oxygen need either insulin or hemoglobin to carry it into the cell. Okay, so on the test, they're going to say you have a patient who's suffering from a diabetic emergency, okay, and they forgot to take their insulin. What will happen to the body without insulin? So on a basic level, what they'll say is that the cells of the body will start to starve, because if there's no insulin, the cells can't get sugar, even though the patient probably could eat. There's no problem with them eating, okay? But they can't get that sugar into the cell, so the cell will be deprived of the sugar, and the cell will starve, okay? And I mean, we'll talk about it in much more detail when we get to diabetes, but that's basically what happens. Okay, now, you don't have to know these terms, mitochondria and adenosine triphosphate and any of that stuff. You know, there's not going to be a test question on that. But the part of the cell that's the actual power plant, right? So you saw that picture of the cell. You saw there were many structures inside of it, okay? The part of the cell that's the actual power plant is called the mitochondria, okay? And in the mitochondria, it converts the sugar and the oxygen into what its fuel, the cell's fuel. And the cell's fuel is called adenosine triphosphate. So anybody who took a high school level or science level science class knows what ATP, that's the abbreviation of adenosine triphosphate, okay? And that's basically the cell's form of energy, okay? So without that adenosine triphosphate, then the cell cannot make energy, okay? That's the fuel that, the oxygen, the sugar turns into inside of a cell. And again, it's not going to be mitochondria and adenosine triphosphate. Just know the concept that the cell has to take in oxygen and sugar, combine it together to make energy so that the cell can do what it needs to do, whatever its function is. If it's a heart cell or anything like that, that's what it basically does. Hemoglobin is somebody asked, where does hemoglobin come from? So hemoglobin is part of iron, okay? And iron we get in foods we eat. So green leafy vegetables have iron in them. Red meat has iron in them, or anything like that. So that's, basically how we get the hemoglobin into our body, is by foods that we eat and stuff like that. I mean, it's a little more complex than that, but, on a basic level, when somebody has a disease called anemia, it means they have a low level of red blood cells in their body, okay? So women very commonly are anemic after pregnancy because they've lost blood. They're anemic halfway through the month when they have their menstrual cycle because they've lost blood. So if you have a wife that feels tired, chronically and stuff like that, she may need a blood test just to see she might be a little anemic. And it could be something as easily as, putting more green leafy vegetables into her diet, some red meat into her diet and stuff like that. So that's basically, how we do and at worst case, sometimes women are so anemic, they actually have to take iron pills, and that's very constipating. So like a lot of women they don't feel good when they're taking iron pills because it really binds you up, and you have problems going to the bathroom and stuff like that. Okay, so again, just the different parts of the cell, we don't need to know them all, but you have these mitochondria, these power plants floating around the cell, and this is what basically makes the energy. Okay, now you've heard of other things, like you could have cells that become damaged and they turn into cancer. Right? So, people have, say, lung cancer because they smoke cigarettes. What happened? The long-term exposure to the poisons in a cigarette changed the lung cells, certain lung cells, and they became cancerous. And what typically happens when a cell gets changed is they start growing, multiplying, reproducing quicker and quicker, and they crush out everything in its path. So a tumor, when you heard a tumor is a concentration of bad cells, not normal cells, cancerous cells that are growing in the body at a great rate. And as a tumor grows, it destroys anything next to it. It crushes and pushes on and destroys anything next to it. So, most of the time cells are good, but sometimes cells get damaged. Like you could get skin cancer, right? So how do you get skin cancer, God forbid? It's being exposed to too much sunlight. So the sun hitting the cells on the outside of your skin changed them, and you could have cells that mutate and turn into cancerous cells. So, and I mean, you know, a lot of this stuff is very easy to kind of protect yourself. A lot of cancers are kind of easy to protect yourself from, right? I mean, you know, you could prevent yourself from having lung cancer by not smoking, by not being exposed to, depending on what your, you know, profession, your occupation is, by not being exposed to toxic gases or dusts, you know, like even like concrete dust or anything like that, or sheetrock dust, sawdust, right? All that stuff, you know, wearing a respirator when you're doing that type of work will protect you from getting it. Same thing like skin cancer. You know, you just be careful when you're out in the sun, you know, especially if you're light skinned, you know, wear sunscreen, you know, make sure your kids have. I mean, you know, being exposed to sunlight from the time you're 1 year old raises your risk of, you know, getting skin cancer. So if your parents had you covered up and sunscreened, you know, till age 16, you have less of a risk of skin cancer than people whose parents didn't take care of them that way. So it's very important, especially in light-skinned people, right? The darker your skin, the less likely you are to get skin cancer because the darkness of the skin kind of shields you a little bit. And then the closer you are to the equator, right? That's the stronger where the sun is. You have more of a risk. I was talking to somebody, a student one time that grew up in Australia, and he said that in the schools in Australia, I guess, I don't know if it was all year round or, you know, in their summertime, I don't know, but the kids had to come to school with a big floppy hat, or, you know, with a big brim around it. Okay. And long sleeve shirts when they go outside for recess, even though it was the summertime, and they had to have sunscreen or else they couldn't go outside for recess because of the high risk of skin cancer. So, you know, I mean, again, I don't know if those were Jewish schools. That might have been, you know, the public school system, but, you know, it's just something to think about, you know, even here. So somebody asked them, why are people sitting at the beach? Because people are stupid. I would say what's more of a risk is why do people go to tanning booths, right? So that's even more of a risk than sitting outside in the sun. Now, remember, you do need some sunlight, right? Because we make vitamin D by being exposed to the sun. So we do need some sunlight. I'm not saying you should, you know, be pale and pasty and stuff like that. But, you know, when you're out and strong, you know, when they tell you the UV index is high, you know, if you're outside, you should have some sunscreen on. And that will allow you to get the good rays of the sun and it'll block out the bad rays of the sun when you have sunscreen on. Okay, so now, for cells to function, they need a correct balance of water inside of them. Okay, now cells have water inside of them and cells are floating in water. Now remember, cells are not necessarily floating in the bloodstream. You do have blood cells, white blood cells, red blood cells, platelets, right? Those are technically cells that are floating in the plasma inside the bloodstream, but you also have cells in every square inch of your body. And in fact, we are really just one big blob of water that's kind of held in by our skin. Really, if you like squeeze your skin, we have so much water that water should start like flowing out of our skin. And you've seen that when you fast, that what really kills us during a fast is the not drinking. The not eating, for the most part, we could deal with for hours and hours and hours, okay? But it's the not drinking that kind of, you know, really affects us. Hold on one second. Somebody's calling me from work. Hey, I'm teaching. What's going on?
Well, not good if I'm calling you.
I know.
So Nelson's didn't talk to dispatch long about this, and then he didn't call me back. But Eric Say, I guess, has symptoms and tested positive today.
Who has symptoms?
Eric Say, that were the EMTs, and
Okay.
we worked with Glockler yesterday.
Okay.
So now Glockler's in the game today, working the park. So
Oh my God.
what? You know, I mean, it's really a Nelson question. Like, what do they need to do now?
Well, I mean, everybody needs to get tested. And, you know, they have to wear masks and social distance until they get a, you know, hopefully a negative test back. And they probably be tested more than once, you know, like tested tomorrow and then tested in a couple of days.
But so should we try to get that? Like, should we pull them from seeing patients right now, or?
Yeah, I would say it's probably a good idea to pull them from seeing patients.
All right, so at least have them come back, and then
Tomorrow they need to get tested.
so send them home, and Mark, at least for right now. But then you got all the patient contacts and.
Well, if they come back positive, then we probably have to make some kind of notification.
But you know, just see what they come
Right,
back at
right.
first.
Yep.
All right, well, I'll call her and have them bring back and tell her to have Mark call me. And Nelson, I texted him to call me. I know he's probably teaching too.
Yep. Okay.
All right.
You can call me back when you need me. Take care. Bye. Okay, sorry, fun and games. Okay. Okay, so we said that basically, cells need a correct amount of water, right? So that when we're fasting, because we're not bringing water in, the body has to get water from some other source, right? So now I already told you that you have tons of extra water in your body, right? I mean, we could last, obviously we fast for 24, 20, 26 hours, maybe 27 hours, possibly, Tisha B'Av or something like that. So we could last, but when you go pretty much beyond like 2 to 3 days without water, what starts to happen is that the cells start to dry up and shrivel because they've taken every extra ounce of water. So the cells are going to be the priority. The body's going to try to keep the inside of the cell hydrated, and it's going to take all the extra water that it could find, whether that be the water that the cells are floating in, whether that be the plasma in your bloodstream, and it's going to start shifting it into the cells so that if the water part of the blood, right, starts to flow into the cells, the amount of fluid you have, right, instead of having 6 liters of fluid floating through your vasculature, your blood vessels, you're going to have less. Now that's going to make your blood pressure lower. Now, if your blood pressure goes lower, then your ability to circulate blood is going to be affected. So you can see now why you start feeling terrible, right? So when you fast, what do you get? You get a headache, okay? So why do you get a headache? Because your brain is not getting everything it needs to function. It's not getting enough fluid. It's not getting enough salt. It's not getting enough sugar. And it's showing you that by the headache. So somebody wrote, let me read here. Somebody wrote, does fasting affect our body's dehydration at all health-wise? What is merely an inconvenience since the body would have sufficient hydration for the day? So it depends. Like I said, fasting for what we fast, 24, whatever, 26 hours, uncomfortable, I mean, again, we're talking in a healthy person. We're not talking about somebody who's not healthy or pregnant or has other things going on. We're talking about, a healthy person fasting. No, it's not going to have any long-term effect. But people who have heart problems, people who are taking medications, people who already have low blood pressures because they may have other issues, yes, fasting can be dangerous. That's why, in certain circumstances, they're going to have their doctor speak to their rabbi and decide whether or not it's safe for them to fast. Okay, or maybe, throughout the fast, they have to drink small amounts of fluid. So that's something from a medical standpoint in conjunction, with a rabbinical standpoint, they'll figure out the safe way to have somebody, do some type of fasting or something like that. So, there's people who actually believe, right, as far as health-wise, okay, the what they call intermittent fasting, which is like there are people, from the standpoint of health-wise, will, I don't know, go 8 hours every other day and not eat, okay, 10 hours every other day and not eat. There's people who will eat up until, say, from the time they awake till 4 o'clock in the afternoon and then not eat again until the following morning. So that actually has been proven to have some health effect, because if you think about it, if you go back, 4,000 years ago, was it guaranteed that you were going to have food, the amount of food that we eat nowadays back then? No. So the body wasn't designed to have this constant source of food in it. So, we were back then, there wasn't really a lot of fat people. Most people were thin, okay? And not that they were, sickly thin, but they just didn't have this huge amount of food. They didn't have all these processed sugars and stuff like that. So, fasting in itself is probably not dangerous for most people. Is the headache a result of constricted veins and arteries in the brain? So certain types of headaches are, like when people have migraines, a lot of times that's vasoconstriction. But the typical headache that you get when you're fasting is not vasoconstriction. It's not the blood vessels constricting. That is caused by too little water, too little salt, too little sugar, and stuff like that, making it up to your brain. That's why as soon as you eat and drink, you feel much better, because if it was vasoconstriction, you'd have to figure out a way of getting rid of the vasoconstriction before you make yourself better and stuff like that. And even if you say, okay, I know I'm good, like we all do it. Okay, we know we're going to fast, so you drink extra. Okay, you eat extra. Well, the body tries to keep a certain level of everything in your body. So once you're fully hydrated, you're going to start urinating out the extra fluid. So you really can't over drink yourself and prevent you from feeling horrible in a fast. What the advantage of drinking a little extra before a fast is that most of us throughout the day are very dehydrated. because we don't drink water during the day. We drink caffeinated beverages. So if you see your urine is yellow, you're a little dehydrated. Your urine, if you were totally fully hydrated, should be clear. It should look like water, maybe with a slightly little yellow tint to it. So, you know, drinking something before you go into a fast is definitely beneficial because, like I said, we start the fast typically dehydrated. So you don't want to go into a fast a little dehydrated. You want to go into a fast overhydrated so that, you know, by the end of the fast, you'll be slightly dehydrated. Okay, so what happens when you have too little water is the cells shrivel up and die, okay? And that's, you know, again, on a mild level, that's not a big thing because we constantly are producing cells. Now, if you have too much water, okay, in your body, like I said, the body will take care of that as long as your kidneys are functioning, and you'll urinate and get rid of that extra fluid. But if you really have too much fluid, like, you know, again, and this is not something in the Jewish world, but there are, you know, you have stupid kids everywhere. So, you know, stupid teenage kids. So there is a thing of like drinking water, just drinking and drinking in high school, tons and tons and tons of water. Okay, and what happens is if you bring too much water in, just plain water with no electrolytes, no potassium, no sodium, you drop the level, you overhydrate yourself, so you drop the level of those important electrolytes in your body, and that can have consequences. You know, so you could technically, if you bring your potassium down so low, you could actually stop your heart. Right. So, I mean, you know, again, nobody does that, but I'm just saying there are consequences. Okay. So electrolytes are substances that are very, very important. They help with the transfer of information. Remember I said our nerves are really like electrical wires that are sending like a little electrical impulses through our body. So you need these electrolytes to help that happen. Okay. Hold on a second. I think somebody just wrote something. Nope. Okay. So I wrote, you know, draw an analogy, draw a connection between cell metabolism and how a gas refinery turns crude oil, right, the oil that comes out of the ground, into good gasoline that we could use in a car. So again, we don't really need to know this to test, but what basically happens is, right, metabolism, we said, is the burning of sugar and oxygen to make energy, okay? And we had anaerobic metabolism, which is when we do it the right way with oxygen, and then we had anaerobic metabolism when we don't have it. So, and I'll show you those terms in a second. So what happens? The cell brings in the sugar, okay, and the oxygen, and combines it together and makes that ATP, that thing I told you don't have to remember, that adenosine triphosphate, because that's actually the gasoline that the cell needs, right? So the crude oil would be like the sugar and the oxygen, and then the body takes it together and turns it into the gasoline. The gasoline in the body is called ATP. So that's kind of what they're talking about there. Okay. So, and that's never going to be, you know, on a EMT level state exam. Okay, so glucose is important, right? It's the building block of energy when combined with oxygen. So we need to have enough glucose, we need to have enough oxygen. But having enough sugar in itself is not enough because we have to have that insulin that allows the sugar to allows the sugar to leave the blood cell and go into the blood vessel and go into the cell, right? So insulin is like the wheelbarrow that brings the sugar from the bloodstream into the cell. So again, you could eat and have all the sugar you want in your bloodstream. If you don't have insulin, it will not get into the cell. And without it getting into the cell cannot combine with oxygen and make energy. So that's the big issue. And that's why when people are diabetics and their pancreas does not produce insulin, it's basically incompatible with life, right? They have to take artificial insulin to be able to survive. Okay, and that's, you know, I mean, think about it. If you go back, I mean, probably less than 100 years ago, there were no such thing as diabetics because none of them lived. They died. If they got childhood diabetes, they probably died within a couple of days of being born. And nobody knew exactly what the problem was. So it was only, you know, something in the last 100 years where they kind of figured out what the problem is. And then even after that, they had to still figure out, you know, can we get insulin from other sources? So at first, the insulin people took were from animals. Now it's synthetically made in a laboratory, but the first insulin that people took was, you know, from animals. Okay, so we said that the term metabolism, right? So here you see the term aerobic metabolism and the term anaerobic metabolism. So I told you already when we did terminology that when there's either an A or an AN in front of a word, it means without something. So this is aerobic, this is anaerobic. So aerobic, like exercise, aerobic exercise is when you're using oxygen. So typically, you know, when you see these people dancing around and exercising hard and stuff like that, that's aerobic metabolism. I'm sorry, aerobic exercise. So the term aerobic metabolism is when the cell is using the oxygen and the sugar together to make that ATP, that adenosine triphosphate, which is the energy of the body. Okay, when there's not enough oxygen, so there's still enough sugar, but there's not enough oxygen, the body still tries to make energy. The problem is it doesn't make enough of it, and that the waste product, in other words, when you burn something, there's always a waste product, right? The smoke that goes out the chimney, the exhaust that goes out the car exhaust system. There's always going to be a waste product when you're burning something to make energy, okay? So when we have the good metabolism, the top one, the aerobic metabolism, that's carbon dioxide and oxygen. And it's very easy for the body. That's what we were designed to have come out of us. And it's very easy. The body knows how to get rid of that. Carbon dioxide, you know, that the lungs exhale, and water we either reuse or urinate out, right? When we go to the bathroom. The problem with anaerobic metabolism is that we have this acid called lactic acid, which is hard for the body to get rid of. And when lactic acid is stuck in the body, it does not make things work well. So that's the big issue when somebody reverts or changes from aerobic metabolism to anaerobic metabolism. Now, why does somebody change from, why does somebody's body change from aerobic metabolism to anaerobic metabolism? Because there's not enough oxygen. Now, that lack of oxygen could be because they're not breathing well, or that lack of oxygen could be because they are breathing perfectly and there's not enough hemoglobin to bring it into the cell, or maybe they are breathing perfectly and there is enough hemoglobin, maybe there's not enough blood flow, right? So like if somebody's lost blood, okay, there's just not enough blood flow to bring enough blood to all the different cells of the body. So now we're going to talk about the blood flow part of it. So that was a lot in 30 minutes or so. So I'll stop for a second. Does anybody have any questions on what we're talking about? Like we're trying to say, how does the body function to keep it alive, right? So any questions on that? We're all experts on this. Good.
When lactic acid starts getting created, is that a state of shock?
So shock is a state when the cells are not being perfused. Perfused means they're not getting what they need, right? And then when the cells are not getting what they need, then they can't make the good energy. They can't make the aerobic metabolism, so they revert to the anaerobic metabolism. And the waste product of anaerobic metabolism is lactic acid. So in a way, what you're saying is yes. Okay, so, but shock is more complex than just saying, the cells are not getting what they need. That's what we're going to talk about in a second. But
is there a term acidotic, being acidotic?
So acidosis is when you have too much acid, like you have too much lactic acid, then yes, you become acidotic. Okay, so acidosis is a state of high acid in the body. And I think I used the analogy of a swimming pool, right? Anybody who was a lifeguard and you maintained a swimming pool, you know that every day they have to look at what they call the acid-base balance of the swimming pool. So they take some water, they put it in a little device, and they add some different colored dyes to it, and it tells them what the acid-base level is. And depending on whether it's high or low, they may have to add chemicals to the pool to adjust it. So our body does that. Our body is constantly checking, okay, if there's the right balance of acid and the right balance of base, and it's adjusting it. It has those same chemicals that you would add to the pool. It has them already floating in your body, just ready to be used if necessary. So somebody asked a question. Did somebody else?
Metabolism to the cells is like perfusion to the oxygen and to the carbon dioxide.
So let's talk about that. So hold on one second. I screwed up something here. Okay, let me just go back over here for 1 second. Okay, so perfusion would be like the first step, and then metabolism would be the second step. Perfusion is that the cells get what they need, right? So perfusion is that there's enough flow of blood to the cells and that the blood contains what they need. So you have two aspects to it. In other words, that the bloodstream has the oxygen and the sugar, and that the blood is actually transporting it to the capillaries so that it could get to the cells. That would be perfusion, okay? So when we say hypoperfusion, we say that there's, low perfusion to the cells. But then that stuff that's in the bloodstream has to be able to cross over into the cells and be burned up and be used. And that's metabolism. So like the first stage would be getting it to the cells. The second stage would be the cells burning it, using it to make energy. Okay.
Thank you.
Now somebody wrote, is anaerobic metabolism in anaerobic metabolism also if there is not enough glucose? So good question. So in other words, the term aerobic means oxygen. So technically, when you say anaerobic metabolism, it would be not enough oxygen. Okay, not that there's a problem with sugar. Okay, so that's a good question. So technically, anaerobic metabolism is saying you have enough sugar, you just don't have enough oxygen. And I don't know, actually, that's a good question I'm going to look up is like, you know, obviously it's bad if you don't have sugar. Like you have oxygen, you have sugar, it's equally as bad. But I have to find out what the term for that is. Like when you don't have, you know, you have plenty of oxygen, but you don't have enough sugar. Is it still called anaerobic metabolism? I would think not, because aerobic means oxygen, so anaerobic means without oxygen, but I'll have to look that up for you. Okay, so somebody asked a question. Wait, hold on, I'm making this bounce around. No. Okay, so now let's do a quick review of what we did with anatomy, because we're going to move on in a second to a little more complex stuff. So the cardiopulmonary system. So far, somebody asked, what's the reason for heartburn? So I guess they're saying acid. So we all have acid in our stomach, okay? The upper part of our stomach, picture your stomach, the upper part and lower part, right? The upper part of your stomach is full of what they call hydrochloric acid, okay? Some of you in the construction industry have maybe used hydrochloric acid for, you know, like etching concrete or cleaning concrete and stuff like that. So hydrochloric acid is a very strong acid, and we have that in our stomach. The stomach, the upper part of your stomach has a very strong lining, so the acid does not bother it. The problem is that the esophagus, which is the tube that goes into the stomach, doesn't have that lining. Now, the way the body prevents that acid from going up into the esophagus is that there's a valve, right? So it's called your pyloric valve that stops it from going up. But sometimes people either have too much acid or they have a weak valve, and the acid is able to leak up, okay, through that valve and touch the esophagus. And the minute it touches the esophagus, we get intense pain because it's actually burning the inside of your esophagus. And that's what heartburn is. So if you have it once every 6 months because you ate some spicy food, no big deal. But if you're having it, you know, very frequently, it's dangerous because remember I told you all cancer is cells being changed. So if you constantly have the cells on the inside of your esophagus being altered because of this acid, you run a risk of getting esophageal cancer, which is, no cancer is good. But, you know, esophageal is not good, pancreatic's not good, you know, certain cancers that are just, you know, very not good cancers to get. Not that there's any good ones, but I'm saying there's some worse than others. Okay.
Does calcium help this, Thomas?
So calcium neutralizes. Remember we said something is an acid and something is a base. So hydrochloric is an acid and Tums, so you have calcium, you have bicarbonate, you have like baking soda also would take care of an acid. So it's just a chemical measurement of how acidic something is and how basic something is. So acids are on the high side and bases are on the low side. So when you have a lot of acid, if you give a base, you neutralize it, you bring it back towards the middle. So you don't have that pain. So you're not treating the problem, you're relieving the symptoms. So in other words, if your problem is your body's producing too much acid and all you do every time you have a problem is take an antacid, you're treating the symptoms, the pain, okay, temporarily, but you're not fixing the problem. You need a different medicine that will stop. You have a pump that makes the acid. So you need a medicine that stops that pump from producing the acid and stuff like that. What you really need to do is go see a stomach doctor, a gastroenterologist, and figure out what your problem is so you could treat it the right way. Okay, so we've talked about the respiratory system. We've talked about the cardiovascular system, and we said your respiratory system is the combination of your lungs and the passageways that bring air in, and your cardiovascular system is your heart, which is the cardio part, and the vascular is the blood vessels, and then also we have the blood, the fluid, right? Now they're saying cardiopulmonary system. So cardiopulmonary is the combination of these two systems working together, and we know the function of these two systems, okay, is to bring oxygen into the body. Okay, and whoops, what did I do here? Bring oxygen into the body, okay, remove carbon dioxide from the body, and that oxygen that comes into the body has to be brought to the capillaries to be distributed to the cells, okay, and also obviously, you know, the sugar and everything else. So it's a very complex system, but, you know, we all know we're alive and it works very well. Unfortunately, we screw with the system by, you know, the way we live our lives and stuff like that. But, you know, for the most part, it works pretty well. Okay. Now, just a quick review, okay, because we had a lot of terms the last time. So your pharynx down here is your throat, and you have different divisions of it, okay? So the part of your throat that's behind your nose is called your nasopharynx. The part of your nose we see is this little tip over here. It's probably about 10% of your entire nasopharynx, your nasal airway, right? So most of it is you don't see. And you see how it looks like there's like, I don't know, ridges in here. So these are called turbinates. And what happens is that turbinates, think of turbulence, like air turbulence in a plane. As the air comes in, and again, they're showing it as one big, nose, but we know we have a separation, right? So we have a separation between both, we have a right and left side of our nostril. So as the air comes in, it hits these shelves and starts to spin around, and that's the turbulence. And the reason it does that is it wants the pollution in the air, the dust and the dirt and stuff, to get trapped in the mucus of the hair and not go down into our lungs, right? We don't want to breathe that garbage down into our lungs. So, and we also said the advantage of breathing through your nose, okay, your nares is the term for the opening, your nostril, okay? So we know that the advantage of breathing through your nose, we said, is it warms the blood, it oxygenates the blood, warms the blood, humidifies the blood, and cleans, not the blood, the air. It warms the air, okay? It humidifies or adds moisture to the air, okay? And it cleans the air or cleanses the air with the mucus in the hair, right? So the air continues to travel down, and we could also breathe air through our mouth, but most of our oropharynx, right, the part of our throat where our mouth is filled up with our tongue, right? So here's our tongue over here. So it doesn't matter where we breathe, either way it's going to get in. It's just preferable to breathe through your nose from the standpoint of, the air is better that gets in through your nose, okay? But either way, okay, you have your nasopharynx, you have your oropharynx, and then you have your actual pharynx or your throat, okay? So this is, now it starts to enter towards your airway. This is your epiglottis, which is the little piece of bone that's attached to a muscle that when you swallow, closes off the airway. So what really happens when you swallow, if you ever look at your throat, is that actually your trachea, your windpipe, comes upward. Okay, this comes down a tiny little bit, your epiglottis, but actually this structure comes up and you close off the opening to your airway when you swallow, and food travels down this flat tube called your esophagus to your stomach. Okay. Now, if you're breathing, this stays in the open position, your epiglottis, right? And it goes through your glottic opening. So epi means above your glottis. So your glottic opening is your glottis into your trachea, okay? And then your trachea goes down, and we'll see in a second, it goes down into your, splits into two tubes, your bronchi that go to your lungs. On the outside of your neck, right, this area where the air is coming in, you'll see as the Adam's apple, the thyroid cartilage, the little piece of bone on the outside of the neck, which is a little more prominent, a little more visible in men than it is in women. Okay, so that's all the structures. So again, nasopharynx, oropharynx. In a week when we start doing airway skills and talk about the equipment we use, you're going to see that we have an airway we insert in the nose. So that's called a nasopharyngeal airway. People usually just call it an MPA because it's easier to pronounce. And then we have a hard white or green plastic airway that kind of curves around the tongue to keep the tongue out of the way. We call that an oropharyngeal airway. When somebody has a sore throat, it's called pharyngitis, right? Because it's the throat that's inflamed. Okay, so your larynx is also, besides being the opening to your trachea, it's where your voice box is, that it allows you to make sound. So when air travels through that top part of your trachea up here, there's these little cords that vibrate, and that's how you actually make sound, or one of the ways you make sound, also your tongue and other things. Okay. Okay.
Now,
Good.
with the epiglottis, you said it's a bone. Is there a difference between bone and cartilage?
It's actually probably cartilage, to be honest with you. I do not have to look it up what it is. So cartilage is a form of bone. It's just not as hard. Like when you chew on, like you have a chicken leg. So there's part of a chicken leg that's solid bone. You can't really chew it. And there's part of the chicken leg that's, you could crunch on. So cartilage is basically like a soft, cushiony type of thing that usually is where joints are. And it kind of acts as it's easier for the rubbing part of it. It's not hard bone rubbing. So you have two pieces of cartilage rubbing with some fluid between it, and it works well. So people have arthritis. It's actually a wearing away of the cartilage, because a lot of times it's either the cartilage being diseased or the fluid not being produced. So
it's like a ligament?
A ligament is something different. A ligament is a tough strand of tissue that holds a joint in place. So like if this was, your elbow, right? This is your lower arm and upper arm meeting, right? You'd have two pieces of cartilage that are going like this when you move them, and then running across those two pieces of cartilage are the ligaments that tie it together so that it can't pop out of alignment. So it's, it stays together. So it's what stops it from becoming dislocated. When you have a joint that comes out of alignment, it's called a dislocation. Okay. So we talked about the upper airway, right? So that's basically everything above the trachea, everything above the glottis. Okay. And then we have the lower airway, which is everything from your, basically from your trachea down. Okay. So this is the glottic part. This is your Adam's apple. That's why it's showing it so big. It sits on top of your trachea. Okay. Then you have your trachea. Your trachea splits. The medical term for splitting is called bifurcation. So it bifurcates into a right mainstem bronchus and a left mainstem bronchus. Obviously, the right one goes into the right lung, left one goes into the left lung. Remember, it's just a continuation of an air tube. You have your trachea and then into your bronchi. And then your bronchi split like the roots of a plant, right, into smaller and smaller. We call them bronchioles. And at the end of the tiniest bronchioles that are hair-like size, you have the alveoli, right? So trachea, okay, splits into the right and left mainstem bronchus. That turns into bronchioles, and they smaller and smaller bronchioles. Each one of them ends with the air sac called the alveoli, and that is where gas exchange takes place. Okay, so again, this is showing you what they call a bronchial tree, but you have your trachea, your bronchi, and then splitting down into, and again, these look large, but the real small ones are tiny, tiny, tiny ones. These, when they call them tertiary bronchus, they're real small ones, okay, down, and then you have the tiny, tiny bronchioles. Okay. One other interesting thing. If you looked at the trachea and you see how it splits, you see how the right one kind of drops a little straight down where the left one goes a little sideways. So again, I don't know if this is how God made us intentionally or how we developed, over thousands of years. But what basically happens when somebody gets something other than air into the trachea, we call that aspiration, right? The only thing that should be in the trachea is air. So let's say, God forbid, a little piece of food or some water, the person chokes on and it makes it into their trachea, okay? What typically will happen is that if it continues to travel, it'll go into the right lung and the left lung will be unaffected. So some people believe it's kind of like a safety mechanism so that you don't completely block your airway, okay? So that then if you were to aspirate something, 90% of the time it goes into your right mainstem bronchus.
Isn't it because it needs to leave room for the heart?
Nope. No, it's just that's the way anatomically, your trachea splits. It happens to be that the right one is a little pointed down more than the left one. And when things tend to fall into your trachea, the vast majority of the time they go into the right side. Okay. So, interestingly, like when you lean on Pesach, you're actually leaning, this way. I don't know, what the significance of it or is there anything like that. I mean, I know they say that rich people lean when they eat, but I don't know why they picked the left side versus the right side, as far as that goes. The other thing that's interesting, that, or those of you that are, have a little more EMS experience, that the paramedics can pass a breathing tube that basically winds up sitting right about here. So that every time you squeeze the bag valve mask, that every breath goes right into the lungs, where you guys are not going to be allowed to do that. You're going to have a mask strapped over the patient's face, right? So your issue is going to be that this mask is sitting over here. And when you're forcing air into the patient, there's not a guarantee that every ounce of air goes into the trachea, right? Some air could go into the esophagus. Now, if you watch how much you're squeezing the bag valve mask and you tilt back, remember you're doing a head tilt chin lift, so you're tilting the head back. When you tilt the head back, you make it more likely, if you picture the head kind of going backwards, you expose more of this and you make it much more likely for air to go into the trachea. But there's a possibility that some could go into the esophagus. Obviously, if you get air into the esophagus, the stomach is going to get blown up or distended, and there's always a chance they could vomit. And then if they vomit, there's a chance that they could aspirate, right? That vomitus could come up and leak back down into the lungs. And that would be, a very dangerous situation for a patient. But what I was getting at is that sometimes, inexperienced paramedics, when they intubate, they advance the tube too far. And the tube now slides into the right lung. So the way they know that they got the tube in the trachea is they take their stethoscope and they listen over both sides of the chest, and they should air coming in and out of the chest. If they did it wrong and it went into the right main stem, right down into here, they would only have breath sounds on one side. Okay, and then what they'd have to do is bring the tube back up so that because usually when they intubate, the tip of the tube is right here, and they would get good air in both lungs. So that's something you'll see when you start riding on the ambulance, is that whenever the paramedics intubate a patient, they always have to be very certain to listen, and the term for listening in medicine is called auscultation. They have to be very certain to auscultate to make sure that the tube is in the right place. And then we said that the bronchioles end on the alveoli, okay? Now, what I like about this picture is that you have to realize that even though they say it's a sac, it's not one big open sac. It's like a sac with multiple rooms inside of it. And the reason why is that every wall of a capillary has the ability to have this gas exchange. So if it was just one big sac, you'd only have one big wall, right? But by having multiple walls inside of this sac, you have more space for gas exchange, okay? Now, did you ever hear sometimes with women, they say, you know, they go into preterm labor. So a typical good length of pregnancy is 38 to 40 weeks. Sometimes the baby wants to come out earlier, right? And they always say they're afraid because the baby's lungs are not developed. Well, the lungs are developed actually pretty early. But what happens is the cells in the alveoli that make surfactant, which is a substance that keeps the alveoli from collapsing when you exhale, is not produced until later in pregnancy, until like the bottom of the 8th month, early into the 9th month, right? So that's the issue they have, that if these babies are born without sufficient production of this surfactant, this kind of like a gluey substance that keeps the alveoli from collapsing, they would have a problem breathing because every time they exhale, their alveoli would collapse. So it'd be harder the next time they have to breathe in. Now, the other thing to look at in this slide is that, so here's a nice bundle of alveoli, right? And wrapped around the alveoli are the pulmonary capillaries. So the reason they show them as blue and red is that obviously one side of a capillary has to be high in oxygen and the other side has to be low in oxygen. Because what's a capillary doing? It's a connection between an artery and a vein. So the side that's closest to the artery has to be high in oxygen, and the side that's closest to the vein is low in oxygen, because the side from the artery is bringing the oxygen in. Well, actually, since it's the alveoli, it would be the opposite. The alveoli would be sending the oxygen from the alveoli into the bloodstream to be transported, right? Because that's the purpose of the lungs, is to bring oxygen in. So the side that's bringing the oxygen from the alveoli into the bloodstream would be red, it would be high in oxygen. And the side that's taking the carbon dioxide from the bloodstream that was used up so that the lungs could exhale it would be the blue side, right? So in this picture here, what's really happening that we don't see it is that carbon dioxide is leaving the capillaries and being exhaled out the lung, and oxygen is coming into the alveoli and leaving the alveoli and going into the capillaries to be transported around the body. So that's what's basically happening here. And we said that the name for the capillaries wrapped around the alveoli are pulmonary capillaries, because pulmonary is the
From the lungs, it's basically
lungs.
going to the heart, right?
What's that?
From the lungs, it's basically going to the heart, not to the entire body.
No, so from the lungs, it's going to the left side of the heart, and then the left side of the heart is pumping it to the whole body. Right. So the right side pumps it, the low oxygen, to the lungs, gets rid of the carbon dioxide, picks up the oxygen. The lungs then bring it to the left side, and the left side then pumps it to the whole body.
So the pulmonary capillaries is basically exchanging the oxygen and carbon dioxide for the heart.
It's exchanging oxygen and carbon dioxide for the body. The heart is the pump that's circulating the blood.
Through the heart.
Through the capillaries and the alveoli. So the exchange of the oxygen and the oxygen and the carbon dioxide is between the pulmonary capillaries and the alveoli. The heart is just the pump that's circulating the blood to the capillaries. That's all the heart is. Remember, the heart is just a pump. So it's circulating the blood that's getting to those pulmonary capillaries, and then the transfer of the carbon dioxide and the oxygen is between the alveoli and the capillaries.
Right.
Okay, so the term airway just means the pathway from the tip of your nose, okay, to the bottom of your bronchioles. That's your airway. So when they say that you have a good open airway, they use the term patent, okay, P-A-T-E-N-T. You're going to hear this all the time. Does the patient have a patent airway? So a patent airway means that they have a good intact airway and there's no problems with the air getting from the outside of the body down to the alveoli, okay? So it says, why doesn't carbon dioxide get mixed up with oxygen if it goes through the same? It does. I mean, there's an oxygen molecule is an oxygen molecule, a carbon dioxide is a carbon dioxide molecule, and they drift right past each other. They don't combine into each other, but just if you picture I don't know, you picture a glass of water and you start pouring things into the water. So they're all floating in the same water, but they don't actually combine, right? So you have a carbon dioxide molecule, you have an oxygen molecule floating in the same bloodstream, but they don't actually combine together, to do anything. They're floating. They're just traveling. All blood is basically a way to transport things, through the body. So it's just a transport mechanism. And the pump is the thing that pumps the heart is the pump that pumps the blood. Okay, and the blood is what contains the things that the body needs. Okay, so just remember this term, a patent airway means a good airway. Everything's wonderful, like we all have patent airways right now. Okay. Now, an airway obstruction means that there's something that's blocking the airway. So when you did CPR, you learned the Heimlich maneuver, you learned different maneuvers to deal with someone who has a blocked airway, right? So the most common cause of a blocked airway in an unconscious patient is the tongue. So why in an unconscious or a semi-conscious, a drunk patient or a sleeping patient or a drug overdose patient or a patient with low blood sugar, the tongue is a muscle. It's actually one of the strongest muscles in your body, right? So when you're laying flat on your back and your tongue is relaxed because you're unconscious, it slides backwards, right? So if you look at, this picture, here's your tongue. And if you were laying flat where this part's, closest to the ground, the tongue would shift this way. So when air is going past that now, they've narrowed the area, right? Because the tongue is shifting backwards. And it makes a snoring sound. That's what the sound of snoring is. So when you're sleeping and you're unconscious, right, you're in a relaxed state. If you sleep on your back, you're going to have the snoring sound. Some of us even snore when we're sleeping face down. Some of us even snore when we're on our side. It's just that we have probably a little extra body weight. And there's, we have a little weight, or we double chin, all that stuff is kind of pressing and pushing things backwards, no matter what position you're in. Okay, so that's all snoring is. And that's, also what sleep apnea is, right? So people who have sleep apnea, they have a more than a temporary obstruction by the tongue. Now, we've learned, different mechanisms to be able to do things. So if it's the tongue, we have an unconscious patient with snoring, we're going to have devices, okay, that we can use to help keep the tongue out of the way. That's an oropharyngeal airway. If it's a foreign body, so food, toys, we have to try to get that out of the body by doing our different procedures, our Heimlich maneuver on infants, our back slap and chest thrusts. Okay. You could have problems with the airway swelling because of infection. So you've probably heard of epiglottitis. You've probably heard of croup. So those are situations where banging on their back or doing the Heimlich maneuver is not going to clear anything because the actual airway is infected and it's swelling, right? Or what about somebody's riding a bicycle and they don't see a tree branch or they don't see a wire, across a parking lot, and they hit themselves in the neck and they actually take that trachea, which is cartilage, and they fracture it. So there's certain things we can manage, like we can manage a tongue partially blocking the airway because we have devices. We can most of the times manage someone choking because of a piece of food. We can't manage something from an infection standpoint. Okay, we can't manage something from a trauma standpoint. That's going to require a hospital. Okay, so we know that once the air goes down through the airway passageways, it gets into the lungs, right? Now, a couple terms we have to talk about, and I think I showed you this once or twice already. Tidal volume. So the tide, when you go to the beach and you see the tide, that's water coming in and out, right? So tidal volume is the amount of air that you bring in and out of your lung with one breath, okay? So breathe in, breathe out, that's tidal volume, okay? In an adult male, it's about 500 milliliters, and that's why I keep on showing you this water bottle. I'm pretty sure that I looked at this once before and it was 500 milliliters. Yep. So the inside of this water bottle, right, the typical, regular size water bottle is 500 mLs. This is about the amount of air we bring out in with each breath, okay? Now, not all of this air, I told you, makes it down to the alveoli. Why? Because some of it has to fill up the distance from your nose to above your alveoli. So out of that 500, 350 makes it down to your alveoli, and that's available for gas exchange. 150 stuck up here. The next time you breathe, the fresh 500 comes in. It pushes that 150 that was sitting in your nose, your mouth, your trachea, and so on down to the alveoli, and another 150 gets stuck. And that's how you basically breathe. So we have to breathe approximately about 500
Isn't
milliliters.
that 150 doesn't come out with exhalation?
What's that?
Is the 150 struck from the nose to the alveolus coming out?
It is moving in and out, yes. So you're inhaling, right, 500 mLs, you're exhaling 500 mLs, but there's always 500 mLs stuck in your airway, right? There's always,
Why isn't all 500 going down?
because it has to fill up. In other words,
Yeah, but you bring in 500 more, it pushes down the 150 plus the 350, you get 500.
right, so exactly. So it has to, let me see the best picture. So when we breathe, we're bringing 500 mLs of air, right? This picture is your first breath of your life. You're bringing 500 mLs of air, okay? 350 gets stuck here and all the tubes in here. I'm sorry, wrong. 150 gets stuck. Okay, now I shouldn't say stuck, but it takes 150 mLs of air, okay, to fill up this passageway all the way to your alveoli. Okay, 350 actually make it down into your, oh, let's actually do it the other way. So you're breathing in 500, okay, 350 make it down to your alveoli, 150 can't get down. They're still filling up over here. Now, when you exhale, yes, you're pushing out that air, but the next breath, there's still going to be air stuck in here, pushes it back down, right? So no, I'm trying to think of a good way to kind of explain it in day-to-day stuff.
It means that from the 350, there's another 150 that comes back out when you exhale.
No, what it means is that you're breathing in and out 500, but only 350 get down to your alveoli for gas exchange. 150 of it can't reach down to your alveoli because it's still sitting in the upper part of your airway. So, you know, eventually it does make it down because the next breath pushes it down. But I understand what people are saying is that when you breathe in, you have to, before you take your next breath, you're exhaling. Okay.
Right.
But there's always a certain amount of air, right, filling up your trachea, your bronchioles and stuff like that. And that's
You're still gonna have the 150 ml. You're still gonna have the 150 ml stuff inside, but that should be maybe from the 350 what it's changed already, and it doesn't come out all the way.
Right.
If it works with a positive and negative pressure, so you only exhale and only the negative pressure, so it always stays like it's a hollow, it's a cup,
yeah,
it's a bottle.
it's always filled with air. You're never fully exhaling.
Oh, but it's
Good.
It's basically exchanging. It's not filled with the same. The 150. It's not basically exchanging.
Yes, absolutely. The air is moving in and out, so it is exchanging. Okay, so from just a reason I want to talk about the term tidal volume is two things. You're going to be using, or you may have used already in skills, the bag valve mask, right? So the thing you squeeze to force air into a patient. So knowing that a patient needs 500 mLs, you know that the bag valve mask has to have at least 500 mLs. But actually a bag valve mask has about 800 mLs. And the reason why is that when you're using it with just a mask, a lot of times you saw it was hard for you to make a seal. So to compensate or to make up for the fact that sometimes it's hard to make a seal, okay, you have the ability to have extra air in there so that if you have to squeeze a little harder, so you could still get that 500 mLs of air in there, you can, right? So in other words, if you have to empty the entire bag valve mask, the whole 800, you may not be getting that whole 800 in because you have that leakage. Now, the only thing I want to point out is that you're going to go on calls where the paramedics are there, and the paramedics may intubate the patient. They may pass that tube into the trachea. That's when you have to be very careful that you don't want to empty that entire 800 mLs because every time you squeeze the bag valve mask when the patient's intubated, everything you squeeze goes into the lungs. So if the lungs were only designed to have 500 mLs and now you're putting 800 mLs, what's the danger? So one danger is you could actually rupture the lungs. You could, it's called a pneumothorax. You could burst the lungs. The other issue is that somebody just said negative pressure and positive pressure, which is very good. That means you guys are thinking, okay, if I over increase the pressure in my lungs, am I also over increasing the pressure in my chest? And the answer is yes. Now, besides my lungs and my chest, what else do I have? I have my heart and I have a lot of blood vessels. If I increase the pressure in my chest higher than the pressure in my blood vessels, what happens to blood flow? It doesn't work well. So another danger of overpressurizing somebody's lungs is that you actually interfere with blood flow, okay? And you know, this is getting a little ahead of ourselves, but just something to think about. And when that's especially an issue is in a cardiac arrest, because in a cardiac arrest, the only blood flow is CPR. And we said that CPR is only 25% effective as a beating heart. So what's the blood pressure you're generating with CPR? Very little. So now the paramedics show up, they intubate the patient. You're a little nervous at your first code, and you're taking that bag valve mask and squeezing the life out of it. And that means the CPR that's being performed is useless because you've just pressurized the chest to the point where blood can't flow. So just something to think about. So how do we know when we've delivered adequate tidal volume to a patient? You want to see the chest do what? You want to see it start to move. And where do you see the chest start to move? By the diaphragm. So once you see the diaphragm starting to move and you see the chest starting to rise, you know you've delivered an adequate amount of oxygen, because none of us breathe where our chest is fully inflated, right? Unless we're running, we don't take huge breaths. Now, besides the term tidal volume, there's one other term that's a little important, okay, and it sometimes appears on the exam, which is called minute volume. So tidal volume is the amount of air you bring in with one breath. If you times it by the amount of times you breathe a minute, which is your respiratory rate, that equals the amount of air you bring in 1 minute, which is minute volume. Okay, so I gave, if you look at the bottom of the slide, I gave an example. If the patient's breathing each breath 500 mLs, that's the tidal volume, and they're breathing 12 times a minute, which is, you know, an average 12 to 20 average respiratory rate, right? So if you do 500 times 12, that means in 1 minute, the patient's breathing 6,000 milliliters of air, okay? So now what they're gonna say to you is, what could be a consequence if somebody's breathing only 4 times a minute? So let's say they're overdosed on heroin and their respiratory rate drops to 4 breaths per minute, okay, because of the heroin. It's reducing their brain's ability to make them breathe. So the amount of air they move in 1 minute now is dropped down. So instead of being 6,000, if you do 4 times 500, it's only 2,000, right? So what's the consequence of that? It means you're bringing in not enough oxygen and you're not removing enough carbon dioxide. So knowing the little you know right now, okay, how would you treat that patient? So you come upon someone, they're unconscious, they're breathing 4 times a minute. What would you have to do? You'd have to take your bag valve mask and do what? Yep, and ventilate them. Now you'll learn in class that we have an antidote for heroin, which is called Narcan. So yes, you'll start bagging them. And as soon as somebody can put together the Narcan, you'd administer Narcan up the patient's nose, and that would reverse the heroin, the drug, and they'd start waking up and they'd start breathing normally again. Okay.
Why does it make a difference for an EMT the equals how many mLs of he was breathing?
No, so you don't have to do the math, but you have to have this concept that when you come to somebody and they're breathing 4 times a minute, that there's a consequence to it, right? So I'm just trying to explain to you what's the consequence to it. You know, and same thing, let's say somebody breathes, I don't know. So let's say somebody breathes now, you've seen somebody probably breathing 30 times a minute, 40 times a minute, right? Let's say they were running, breathing 30, 40 times a minute, okay? So it depends now if it's breathing fast because they're trying to exercise, that's probably okay. But let's say somebody's having respiratory distress, okay? And they're having trouble breathing and their oxygen level is starting to drop and their carbon dioxide level is starting to rise. And they're reverting now to that anaerobic metabolism. So they have lactic acid building up in their muscles. I gave you the analogy the other day, you're working with your hands above your head, okay? You're fixing something with your hands above your head. After about a minute or so, your arms start to burn, they get tired. Okay, that's because you're not getting enough blood flow because your arms are above your head. But actually what's happening is you're reverting to anaerobic metabolism, right? You're getting lactic acid in your arms and they're getting shaky and tired. So the same thing could happen to your diaphragm or your intercostals. So now instead of contracting and moving air the way it should, it looks like they're breathing, but they start to breathe shallow. So instead of bringing 500 mLs in, they start to bring in 300 mLs, okay? The other problem when you start breathing fast is that you have to have a certain time to breathe in and out, right? You have to have, in other words, enough time between each breath to bring enough air in and out. So when somebody starts to breathe real fast, they don't have, because you know you're squeezing in more breaths in a minute, you don't bring in enough air. So there's different ways that we could reduce this minute volume, and it could be bad for a patient. And you know, as we talk about respiratory emergencies, we'll kind of get into it. So 2 new terms. Okay, you know that brady in front of a word means slow and tachy in front of a word means fast because you saw bradycardia. Cardia means heart rate. This is a different term, but bradycardia means a heart rate below 60 and tachycardia means a heart rate above 100. So now we have 2 terms. We have bradypnea and tachypnea. So this is when you have PNEA in front of a word, it means breathing, okay, or I'm sorry, the letters P-N-E-A means breathing, right? So bradypnea is a respiratory rate that's too slow, okay, and tachypnea is a respiratory rate that's too fast. And I know, we said 12 to 20 is normal breathing, but different books, different places in different books, they have all different numbers. So here they have 10, they have 28. Don't fixate too much on the actual numbers and stuff like that. So just a new term, right? So, I mean, again, I don't hear EMTs very often saying bradypnea. I do hear EMTs saying they're tachypnic. So you walk in and somebody who's having trouble breathing, and you may hear an EMT or paramedic say the patient's very tachypnic. That means they're breathing very fast because they're trying to compensate for that having trouble breathing, okay? I want to give you a break in a minute.
There's a number of fast breathing when you have to ventilate as well, right?
What do you mean when you have to ventilate?
Let's say the patient do back value mask, if the patient do like 35, 40 breaths a minute.
Okay, so you're saying somebody's breathing too fast and you would treat that with the bag valve mask?
Yes.
Okay, so that is a great thing that's in the book, but picture this. Picture you're having trouble breathing. And yes, you're breathing 38, 40 times a minute. And I'm the EMT and I come and I say, I'm going to make you feel better because I'm going to take this bag and mask and stick it over your face and try to get in sequence when you breathe in and squeeze the bag valve mask when you breathe in. So in theory, it's a great idea. In actuality, what will the patient do if they're having shortness of breath and you stick this thing over their face?
Throw it away.
Yeah, they'd look at you like you're crazy. They'd actually probably push you away.
Right.
So there's going to be things, remember I told you there's book knowledge and there's real life knowledge, okay? We do have a device called Cpap. You've heard of Cpap where people have sleep apnea, right? It stands for continuous positive airway pressure, which is a device that helps people having trouble breathing breathe, okay, forces air into them. That's a device we use in that situation where somebody's breathing inefficiently to help them breathe deeper, because again, you have to breathe deeper to get the air down to your alveoli, but it's the same thing. You have to sell the patient on the idea. So it's kind of doing what you were describing with the bag valve mask, but it's kind of a better way of doing it. But not every patient tolerates it, because when you're short of breath, if somebody puts something over your face, you freak out. It's just a psychological effect of it. You kind of freak out. So it really comes down to you being able to convince the patient that you know what you're doing and that you're going to make them feel better. So it's almost like being a used car salesman. Trust me, I know what's best for you. I'm going to help you. And you've been to doctors where you had total confidence in them. And you've been to doctors where you say, this guy doesn't know what he's talking about, and I'm going to go to someone else as soon as I get out of here. So it's the same thing with us. It's a matter of, if you walk in the room and you look scared and sweaty, they're going to realize that you're new, you don't know what you're doing, and you're worried about them. And so if you're scared, they're going to be scared. And that just comes with time and experience. But there are certain people that are always calm, right? You know people yourself that the whole place could be exploding around you and nothing phases people. They could always appear calm and in command. And that's a good skill to have, that no matter what's happening, you don't get rattled. And that's always the big joke about a hot solo call. You got 20 guys screaming and yelling at each other, and who's taking care of the patient because everybody's screaming and yelling. So sometimes, in the Jewish world, the loudest person is the person that gets listened to when they may not necessarily be the smartest person, right? They just happen to be the loudest, pushiest person. Okay, so we're going to take a break in 1 second, but let's just finish up with this term here, and then these couple of slides right here, and then we'll take a break, okay? So we know that control of breathing, control of respirations is controlled by your brain, right? Control of heartbeat is controlled by your heart itself, but control of the lungs is by your brain. And we said that the part of the brain that controls breathing is called your medulla, right? Your medulla oblongata or your brainstem, right? And that's the part that has the sensors. And what's it actually looking at? Does anybody remember how your body decides to breathe? What is it looking at to decide whether you breathe more or breathe less? The level of what? It's
carbon dioxide going out.
Yes, it's the level of carbon dioxide. It's not the level of oxygen in a healthy person. So if the carbon dioxide's high, it's going to say that's bad. It's going to make you breathe more. And if the carbon dioxide is low, it's going to say your breathing is good, and it's going to make you breathe slower, okay? Now, once it decides how often you should breathe, then it sends signals to your diaphragm and your intercostal muscles to make you change the size of your chest so air can come in and out, okay? So people could have, now we're going to talk about why do people have trouble breathing. So the first thing is that people could have trouble breathing because the brain can't function well. Now, the brain could not function well because it got hit, there's trauma, there's bleeding, there's an injury, they got hit by a car, they're on a bicycle, they didn't have a helmet on. You know, so that's the first thing. You could just have a physical damage to the computer, right? Like you drop your phone, it may not work well. The other issue is that the brain may not be getting the things it needs to function. So the brain, like every other part of your body, needs oxygen. So the term hypo always means low, and oxia is oxygen. So hypoxia means there's low oxygen, right? So who knows, they're having trouble breathing, okay? Or it could be sugar problems. So hypo means low, glycemia means sugar. So hypoglycemia is low sugar. Well, we know the brain needs oxygen and sugar. So if it doesn't get that, it's not going to work well. There could be an infection. You've heard of meningitis, encephalitis, right? All the different infections in the brain. We just talked about a heroin overdose. So heroin is a form of drugs called opioids, opiates. Opiates suppress the ability of the brain to work. It kind of sedates the brain so that, you know, it can't do that monitoring of the carbon dioxide. So those people have trouble breathing. There could be poisons in the body, okay, or trauma, right? So again, just very basic, just introducing the concept that when you come to somebody and they're not breathing properly, there could be multiple different reasons why it's happening. Sometimes you can correct it. So if you know the oxygen level is low, okay, you give them oxygen, they might be better. Their sugar level is low, you give them sugar, they might be better. Sometimes we're not going to be able to treat them. So what do? We just ventilate them with the bag valve mask, okay? And we're not fixing necessarily all the time the problem. What we're doing is raising the oxygen level so we prevent there being any further problems. Now, another way people could have problems. So we're talking here, the computers not functioning. Now we're talking about there's a problem with pressure, right? So we said that we breathe by changing the pressure inside our chest, and that when we inhale, our muscles are contracting and making our rib cage bigger. So if our rib cage becomes bigger, as it expands, it's pulling your lungs with it, and it's dropping the pressure, right? So if something gets bigger, the pressure inside of it gets less. And once the pressure inside your chest, inside your lungs gets less than the pressure in the room, air will flow in because it's going from high pressure in the room to low pressure in your lungs because you've made your chest bigger. Now, that requires that there be an intact chest, intact lungs. So if you have any kind of trauma where there's holes in your chest, a hole in your lungs, that's going to interfere with it. Okay, or maybe you're bleeding inside your chest and your lungs can't expand. Okay, so I gave you the analogy the other day that there's a piece of glass, two pieces of glass with a drop of water between them, right? Now, that glass will slide this way, right, back and forth, fine. But if you try to separate them, it's very hard. And sometimes you'll see that on your kitchen counter, like if you have granite or something, and you have you have granite with a little bit of water on top of it, and you put like a cutting board, a smooth cutting board on top of it. It will stick very well. It'll slide back and forth, but it'll stick very well. And that's what happens inside our chest. In that you saw spare ribs, right? You saw like a rack of ribs. You turn the ribs upside down, there's a shiny layer, okay, inside those ribs. So that shiny layer is on inside the ribs, outside the ribs, right? Now, your rib cage, right? You have that shiny layer on the inside of your rib cage. You also have it on the outside, but we don't really care about that. But you have it on the inside. And you also have that shiny layer, okay, on the outside of your lung. And that's what the term pleura is. Pleura is that shiny line. When you'd say visceral pleura, visceral is always on an organ. Parietal pleura is on the inside of the rib cage, is the cavity, right? So picture this, you have a lung. Your lung is inside your chest. So your rib cage is here, right? That's your chest. And you have your lung. They're basically pressing together. And in between the outside of your lung and the inside of your rib cage is a thin amount of fluid. And now you want to inhale and bring more air in. So what happens is your rib cage expands. And as it expands outward, the lung is attached to it now because of that fluid. And it actually expands your lungs and makes them bigger. So the pressure inside of them drops. And now air flows in. So this is the inside of somebody's rib cage. Okay. Obviously a dead person. And they're actually grabbing that shiny layer. So you don't really see that layer, right? I mean, you know, when you look at the inside of a rack of ribs, you kind of see it, but you don't really ever peel it off. So that's what they're showing you. So this would be the inside of somebody's rib cage. There would be a thin amount of fluid and it would be pressing up against the lung. So in this situation where this gentleman had a 2x4 that penetrated his chest, what happens now to pressure? Okay. So again, it's a little low. This one looks, you know, like it went kind of into his abdomen a little bit. But what would happen if it was a little higher as far as his ability to breathe, right? And I mean, obviously the piece of wood filling up his chest is going to be an issue. Probably would have pierced his lung. But just, you know, if you make a hole on the outside of the chest, then you don't have those pressure changes happening as easy. So when we talk about trauma, somebody's shot on the chest, we're going to talk about one of the important things is to reestablish what they call the integrity, the solidness of the chest by maybe sealing that hole. Okay. Anybody know who this handsome person is over here? Anybody have any idea who this guy is?
See the glasses.
That's me.
You.
All right. That was one of the better calls.
Yeah.
What's that?
How do you go? How does a 2x4 goes in a person?
Well, first of all, it was 8 feet long until we cut it. And this was a, you know, when you have a picket fence, you have a wooden fence, there's two pieces that go this way and then the other wood is nailed to it.
Okay.
So he was driving a car and he crashed into this fence, and this came in through the passenger window. He was the driver, came in the passenger window, traveled across the car and went into him. And he was alive.
Survived?
He was alive. He was talking to us. I mean, he died, but he was alive. He was alive for a couple hours. So he was alive the whole time I had him. Yep.
The only question is how you kept the pressure. To me, it looks like it went through his stomach.
No, this is not a lung. This was not really a lung. So one thing you have to realize too is that here's where the diaphragm goes, right? It basically goes right along here. So right now, if he was exhaling, the diaphragm would be high, right? Because it's the muscles relaxing. But if he was inhaling, right, your diaphragm travels down low. Now, again, this is pretty low, so it probably wouldn't hit his lung. But depending on the phase of breathing, when somebody has a puncture wound, an injury, whether it be a shooting, a stabbing, a 2x4, whatever it is possible to always hit the bottom part of the lung if the person's inhaling when the object goes into them, right? So it really kind of just depends on, you know, when it happens. So it's something you should always think of. In other words, you get somebody stabbed, okay, and it's really looks like it's more towards the stomach, but the guy's complaining of trouble breathing. It might have been that he was stabbed when he was inhaling and the knife was aiming upward, okay, and it might have actually went through his lung because he was inhaling, and that's why he's having trouble breathing. So whatever, we'll talk about this much more when we do trauma.
Now, when you say that if there's a hole, you could clog it.
So somebody shot and has a bullet hole, okay? So one of the things that we're going to learn is that we can take what they call an airtight or occlusive dressing. So, I mean, a piece of plastic wrap, you know, that you have in your kitchen. I mean, that's not what we use, but something like that, and tape it down to the patient's skin. So now that hole doesn't exist anymore because we resealed the chest. So that's the concept.
Okay, but isn't there, you have this liquid in between the chest and the lungs?
So yes,
So
could some of that leak out? Yes, but that's not at that point. It's more important to reestablish the solidness of the chest.
No, it's not. It's not about leaking out. Is it still gonna create the pressure? It's still gonna when chest expands.
Yes.
Isn't
that's a
the
great
blood
question.
getting in or something?
Yeah, that's a great question. Are you still going to have the lung sticking to the inside of the rib cage so that the lung can expand? Probably not as well, but yes, you will still have it somewhat. Okay, so we'll finish up now, and we're going to take a break, right? With respiratory dysfunction. Dysfunction means it's not functioning right? So the long and short is that if something interferes with the ability to lungs to work right, that could be the brain not controlling it. That could be they got a piece of food stuck in their trachea. That could be that the chest wall has been damaged, whatever it is, okay? There's going to be some consequence. And the consequence basically is that you're not going to get the same amount of oxygen in, and you're not going to get the same amount of carbon dioxide out. And both are equally important. A lot of people always think that oxygen is more important than carbon dioxide. But carbon dioxide is a waste product. And if the waste product builds up into your body, it poisons your body, right? And the way you see too much carbon dioxide in the body is the patient starts to get sleepy. So just again, so we keep on reviewing terms, okay? Hypoxia is the medical way of saying low oxygen. So you're going to hear people say a patient is hypoxic, right? Or has hypoxia. All means the same thing. It means the level of oxygen is low. So again, how do you treat that? Well, if they're breathing on their own well, you give them supplemental oxygen through an oxygen mask. If they're not breathing well on their own, then you use the bag valve mask, right? And we have a couple other devices. Now, the other issue would be they could have high levels of carbon dioxide. So we call that hypercapnia, right? Hyper means high, capnia means carbon dioxide. Nobody ever uses this on an EMT level, okay? But how do we get rid of carbon dioxide? So again, if they're not breathing deeply, The only way to get rid of it is to increase the depth of their breathing. So we said in a patient who's unconscious, we have the bag valve mask. And in the patient who's conscious and having trouble breathing, we have Cpap. And, you know, this is early in class and stuff like that, but just to realize there are things we could do, okay? But the one thing you never want to do is stay on the scene excessively, okay, on a patient. So somebody wrote 2 things and then we're going to take a break. We are not taking out the boat. We take him to the hospital with this, correct? I don't know what that one means. So that somebody's going to have to translate. I don't know what the boat is. And then it says, yes, you can do more damage when removing. Oh, you mean the wood? You mean this guy? This gentleman over here that I had? Yes, so you're not pulling that piece of wood out. What we did was he was upside down, seatbelted in the car when I got there. And that piece of wood was sticking out the window. So we got some little tiny volunteer fireman guy to crawl in the car with me. And he actually went under the patient so that when we took the seatbelt out, the guy kind of fell on his back. Picture the guy's like crawling on his hands and knees, and he kind of raised his back up so he was supporting the patient that was hanging upside down in the car. Before we cut the seatbelt loose, we took a Sawzall, a reciprocating saw, battery out reciprocating saw, and somebody held the wood and we cut it right here. So it was a little more manageable because we couldn't get the guy out of the car. He actually was telling us that he felt like he was stuck on something. So he didn't know exactly what he was stuck on, but he said he felt like he was stuck on something. And once we were able to cut it, we were able to, you know, slide him out. I mean, the car was upside down. So the, you know, the windows were, the roof of the car was resting on the ground. We were able to bring a backboard in and slide him out onto the backboard and get him up. He was up down a little hill, get him up the hill into the ambulance and stuff like that. But like I said, the guy was conscious, talking, very minimal bleeding. I mean, very minimal bleeding. And he had good lung sounds. His lungs were working and everything. What happened was when it went in, it destroyed his liver, right? You have a liver as your right upper quadrant. It destroyed most of his intestine. If you notice over here, can you see the wood is kind of bulging out on this side of the picture? It actually was all the way across him. It didn't come out, but it was kind of trying to come out. It actually broke his spine. And the reason he was so cooperative is that he couldn't feel anything. He was paralyzed from the waist down. He had no sensation of pain. So that's why he was so cooperative, because he wasn't in any pain. He didn't feel anything. And they took him to the operating room and they removed it. And when they removed it, he instantaneously went into cardiac arrest and died. So he lasted about 3 hours. But he was drunk. He was drunk as a skunk, driving his car, crashed. I mean, at least he didn't hurt anybody else. That was the only good part of it. Okay, so it is 9:33. So take a 15-minute break, come back about 9:45, and we'll pick up again for a few minutes, and then we'll finish up tomorrow. Okay? Question. Yes.
When you intubate, you have to do 350 or 500, because you said that the lungs gets only 350 milligram.
So when you ventilate again, you're going to judge the tidal volume, how much you're going to squeeze the bag valve mask by chest rise. That's always your best indicator. You squeeze the bag valve mask just till you see the chest start to rise on the patient. And then you know you're getting an adequate amount of air in. So there's no way to bag valve mask to measure how much you're squeezing. In other words, how much air is going in. So it's got to be a visual thing where you're looking at the patient when you're ventilating and you're seeing the chest. What's that? Okay. Okay, so take a break, stretch your legs, and we'll be back in a couple minutes. In the important states.
Dying.
Dying?
It's picking up by the minute every second, more and more.
He or the she? Who are you looking for?
I'm looking for Trump.
He just got Ohio. Ohio got the red now.
Oh, yeah?
Yep.
Okay. Okay, so I'm going to start recording, so let's not do politics. So,
maybe it's not shouldn't be recorded. You said last week you're going to teach for doctors. What does a paramedic have to offer for doctors? Maybe just technical?
So there's 2 or 3 classes that I do. One is called Advanced Cardiac Life Support, and one is called Pediatric Advanced Life Support. So those are classes that deal with like resuscitation, you know, like a cardiac arrest type of situation. So, you know, again, the classes that everybody has to take, and it's the care that a paramedic would do in those situations is the same as a care that a doctor would do, you know, because it's the emergency part of it. to a certain extent. Obviously, there's more things that a doctor could do, but so that was. And again, today I just taught to radiologists. Those are doctors that read X-rays and stuff like that. So it's not like they're routinely resuscitating patients. Not like, let's say, an emergency room doctor. So they whatever I tell them, they nod their head and say yes, basically. So okay, so let's. Yeah, I actually would have to have Tab come teach. He's a little busy right now, and he was excellent before he was a doctor. I'm sure he's going to be excellent after he's a doctor. So he's a great guy. And then we have another one too. We have Abe, and we have what was his name? Lubavitch guy. Yitzi Goldsmith also became a doctor. So we have two gentlemen. Okay, so any questions or anything before we start up?
So I want to know, the alveoli they basically transfer. That's what happens in the lungs. The blood then, where does it goes back to the heart, and then it goes into the bloodstream, right?
Right.
Back into the aorta.
So the right side of the heart pumps the used up blood that came back to the body to the lungs, and that's where it gives up the carbon dioxide and it gets the oxygen, and that giving up and getting takes place between the pulmonary capillaries and the alveoli. So once it gives up the carbon dioxide, the lungs exhale it, and the oxygen that came into the bloodstream then goes back to the left side, to the left atrium, goes to the left ventricle, and then you're right, it pumps out into the aorta and goes to the whole body.
Okay, now when it gets to the place where it needs to go to transfer to all the places in the body, how does it exchange again? Is it through the capillaries?
So here, look at this. So can you see the screen share?
Yes.
Okay. So what this is basically showing you is the red is the arteries and the blue are the veins. So this is a very good picture. So a lot of times we think that at the end of every artery there's a capillary, and then off the capillary there's a vein. But actually, this is a good picture. If you picture this vein being, I don't know, 100 feet long, this artery being 100 feet long, and this vein being 100 feet long. Every square inch, I know it's showing like it's just in one place, but all along between this artery and the vein are the capillaries. And all the capillaries are a connection between the arteries, okay, and the vein. And what happens is that the oxygenated blood crosses over to all the cells that are in this area, and the same thing would be going on this side. So like you're showing you on one side, but you'd have the same thing off the other side. Connecting off the arteries, the smaller arteries that we call arterioles, are the capillaries. So every square inch, every foot of an artery has a foot of a vein right alongside it. In between that is the capillaries connecting the two of them. So throughout your entire body, there's just miles and miles, hundreds of miles, thousands of miles of capillaries, okay, that are connecting, all the blood vessels of the body. So that's kind of what happens. So that all the cells that are in this vicinity are being nourished by these capillaries. All the cells that are in
every cell is connected to the capillary.
So we're billions, and so I mean, basically, what you just have to think is that every square inch of your body is just made up of thousands of cells, and there are capillaries throughout there's not a piece of your skin, there's not a piece of inside of you that doesn't have capillaries bringing blood to it. So your entire body is filled up of cells and filled up of blood vessels, filled up with capillaries, and this is happening everywhere. It's not just happening in certain places, it's happening throughout your entire body. So, that's why if you cut your skin, you bleed, because if it was just, arteries and veins with a couple of capillaries every so often, there's a chance that you could cut a piece of skin and not bleed, because there doesn't happen to be a capillary in an artery, or a vein or
so
something.
Now the blood leaves, not the blood, the oxygen and the sugar leaves the capillaries, and it goes into the
cells that are close to it. Yep.
Now the cell is not connected to the capillary, right? It's just next to it.
They're next to it. Very good. So the wall of the cell is next to the wall of the artery. I'm sorry, the wall of the capillary. So, you know, basically you have to have in close proximity, you know, close distance, the wall of a cell and the wall of a capillary. That's why there's so many capillaries, because there's so many cells.
Okay.
Okay. So let's go back to the respiratory system for 2 seconds, and then we will pick up. So let me just, hold on 1 second, make sure we're recording. Yeah, we're recording. Okay. So we were talking about all the problems people could have with breathing and stuff like that. And I mentioned to you that the body monitors the level of oxygen and carbon dioxide in the body. And it really looks in a healthy person more towards carbon dioxide. And we said if the carbon dioxide levels are high, it tells you to breathe more. And if the carbon dioxide levels are low, it tells you to breathe less, right? So CO2 is the chemical that it looks for in healthy lungs, and oxygen is what it looks for in unhealthy lungs. So COPD is the abbreviation for chronic obstructive pulmonary disease. It is basically emphysema. You've probably heard of people having disease of emphysema. It is a disease caused by long-term exposure to either toxic gases or cigarette smoke. And what happens is it changes the alveoli. So instead of being a sac with multiple rooms inside of it, it becomes one big floppy sac that doesn't exchange air very well. That's what happens when people smoke for, 30 years and they get this disease of emphysema, or people were working in an industrial setting without having a respirator protection on their face and they were exposed to it. Okay. So just a term to put out there. Okay. Remember, the body has to have a way of monitoring this, right? They have to have like your heat in your house. You have a thermostat that's telling your furnace or your boiler whether the house is hot or cold and whether it should turn on or off. So we have that same concept. We have receptors, right? We have these thermostats, these receptors. A thermostat is more for heat, but we have these different receptors that are monitoring different things. So throughout your body, you have what's called chemoreceptors, chemical receptors, and there's different chemical receptors for different chemicals in your body. There's some for sugar, there's some for oxygen, there's some for carbon dioxide, and these are just bundles of nerves. Remember, nerves are the wire that either takes information from the brain and brings it to the body, or takes information from the body and brings it back to the brain, right? So we had sensory nerves bringing information back to the brain, and we had motor nerves that take that information that the brain got and send it back to the body to do something. So in this case, in the blood vessels, there's these special receptors that are looking at the levels of carbon dioxide and oxygen. And if the level in a healthy person like us, okay, if the level of carbon dioxide is rising, it makes us breathe more. Okay, so again, it says the brain stimulates the respiratory system to increase its rate and tidal volume. So when would it tell the brain? When would the brain tell the respiratory system work faster and harder? If the level of carbon dioxide was higher. Okay, now when somebody has this disease, this chronic obstructive pulmonary disease, the problem is that because they have unhealthy lungs, their level of carbon dioxide is always high. Okay, so the body gets, and we're talking this took 20, 30, 40 years to develop. So the body is now getting tricked by these chronically high levels all the time of carbon dioxide. So it says, I can't trust the level of carbon dioxide anymore. So what it does is it switches to the level of oxygen. Now think about it. We have a theoretical problem here. So if it's saying that it's going to breathe more, okay, when the level of oxygen is low in this unhealthy person, right? And it's going to breathe less when the level of oxygen is high. Now we come to somebody who has emphysema and they're having trouble breathing, and we say, oh, they're having trouble breathing, let me put them on oxygen, okay? So now I raise the level of oxygen in that person, and what does the brain say? Well, the level of oxygen is good, so let me slow down the breathing. But we don't really want to slow down the breathing because they're having trouble breathing. So, as we get deeper into class, we're going to talk about that there can be situations where oxygen can actually be harmful in patients, right? So right now we're thinking oxygen is a wonderful, thing. Everybody should have plenty of oxygen because you need oxygen to have a metabolism, to have aerobic metabolism, right? So, but we'll talk about more and more that there's, situations where, God made us in a way that we're supposed to have a certain level of everything in our body. Too little is not going to be good, and too much is not going to be good, okay? Now, obviously, when we were designed, nobody smoked cigarettes. Nobody was exposed to toxic gases. So these are changes that came around after the body was already designed. And that's why the body can't handle that. And that's why there's disease, okay? Okay, so let's just go on, and we're gonna finish up in a couple minutes. So we talked about the lungs ad nauseum. Let's talk a little bit about the cardiac part of it. So we said we have blood, and blood has 4 parts to it, right? So we have plasma, which is the fluid portion of the blood that has 3 cells floating in it. It has red blood cells, okay, that are called erythrocytes, another term for them. And they have a substance, a protein on them called hemoglobin, and that's the part of the red blood cell that actually carries the oxygen. And why does it have to be there? Because for some strange reason, the cells will only accept oxygen into them if hemoglobin is carrying it in. So it's like somebody comes to your door to bring you something that you really want, but you're not going to let them in because you don't know them. So it's the same thing. The cells really want oxygen, but unless hemoglobin is there to bring it in, it's not going to let it through the wall of the cell. And it would rather die than let the oxygen in if hemoglobin is not carrying it in.
The concept of having something to let in, like here, is very, very common when you take medicine, especially in chemo, certain brain, the brain has a brain barrier. With hydroxychloroquine goes to the Dr. Zelenko's thing. You needed the Z-Pack in order to zinc. Right. The cell should open and take the zinc.
Yep. It actually has a term. It's called active transport. In other words, the concept that the cell will let certain things in without it being carried in by something else. Right. So, I mean, there's certain things the cells will readily accept. Water, right? They'll readily accept water all the time. So there's certain things they will. There's certain, just happens to be the way we're made, okay, that certain things have to be brought in. So oxygen is one of them, and sugar is one of them that we talk about in the EMT level. Again, hemoglobin brings in the oxygen, insulin brings in the sugar. So what other cell do we have in the blood? Is the white blood cells to help fight infection. And there's other substances in your body besides white blood cells that fight infection, right? White blood cells are the earliest, a lot of times, okay, that fight infection, okay? And then we have platelets, which help with bleeding control. But again, there's other substances, fibrin and different substances that also help with bleeding control, right? So
what is the CBC blood test? What is the CBC blood test? What I can see?
So it says complete, CBC means complete blood count. So it's measuring every part, you know, everything that's in your body to be able to be measured. I'm sorry, not in your body, everything inside your bloodstream that's able to be measured. So yes, you're getting a red blood cell, you're getting a white blood cell, you're getting platelets, but inside of those cells, there's other things. So it's looking at the hemoglobin, the hematocrit. It's looking at like multiple things that, again, it's a nice to know on an EMT level, but it's not a need to know. You know, in other words, we could spend, you know, we could stay here for 20 years and, you know, all become super educated, but what's our function, you know, as EMTs? Our function is to take care of patients for 15 to 20 minutes in an emergency setting and do what we could do to get them to the hospital. So I'll tell you what tends to happen is the more knowledge you have, the slower you are. And you tend to think sometimes too much instead of saying, okay, let's just do what we could do and get them to the hospital. Like when I first started as a paramedic, we couldn't do fancy EKGs. We couldn't do this. We couldn't do that. Personally, I think we took better care of patients. Now we have all this machinery and we tend to sit on the scene analyzing all this stuff. We're not going to fix the patient in the house. Right? I mean, it's very rare that we could fix a patient in the house. So really, it just kind of delays a lot of times transport. Now, there are paramedic systems when they're in the middle of nowhere that they actually try to fix the patient in the house, right? So somebody has a cut and it's infected. You know, they can clean the wound, they can suture the wound, they can give antibiotics. We don't do that in, you know, New York for the most part because we have hospitals all over the place. But if you were in Montana and it's 2 hours to a hospital by ground, you know, they train the paramedics to do that, right? And stuff like, so we do have in Rockland County, we do have a separate, you know, we have the 911 emergency paramedics, and then we have what we call community paramedics, where we actually go manage, almost like a visiting nurse service, we go manage the chronically ill patients to keep on going back and forth to the hospital and try to care for them in their homes so they don't keep on going back to the hospital. It's a program the government funds to save money, right? Because if a patient goes to the hospital, the government spends money. So they fund this program to try to keep patients out of the hospital. Okay, so without enough blood, oxygen and carbon dioxide cannot be properly moved around, right? So blood is the transport mechanism, but we know that there could be plenty of blood and everything's working fine with the pump, and if you're choking, you're not bringing enough oxygen in, right? So there's a lot of different ways that you could have problems, and that's what you have to start being able to analyze or think about as an EMT, right? So somebody's lips are blue, and they're not cold, they have cyanosis, and you know there's a low level of oxygen in their body, but yet to you, they seem like they're breathing fine. So maybe it's not a problem with bringing oxygen in, maybe it's a problem with getting that oxygen to the cells. So maybe it's a pump problem, or maybe it's a problem that there's plenty of oxygen being breathed in, but there's no hemoglobin because the person was bleeding internally because they had an ulcer, and then that oxygen couldn't be transported, right? So again, there's more to think about. So a lot of stuff we can't correct, but some stuff we can correct, or some stuff we could at least temporarily, patch it up enough to get them to the hospital alive, right? So there's all different problems that somebody could have, right? So anemia means that there's not enough of the red blood cells. So if there's not enough red blood cells, there's not enough hemoglobin, okay? So I think this is a fantastic picture, but just picture that it shows it in one little spot, but just picture this capillary bed traveling all along these blood vessels everywhere they're going to the body, and picture there being 1,000 more of these blood vessels, and all we are is basically miles and miles and miles of arteries, veins, and capillaries, many more capillaries than arteries and veins, because you could see that the capillary network is much more diverse, much more prevalent between the arteries. And it's at this level, these are, again, you can't see these with your eyes. At this level, the walls of these blood vessels, these capillaries, are paper thin, right? And it's very easy for things to leak in and out of them. So what leaks out is the good stuff. What goes into them is the bad stuff. So you want the good stuff leaving the arteries, leaving the capillaries, getting into the cells, and the waste products in the cells entering into the capillaries to be transported by the veins back to either the lungs to exhale, like carbon dioxide, or the kidneys and liver to be cleaned and removed from the body. Okay, so that's kind of what happens. Okay, so they take oxygenated blood from the lungs, okay, pumped by the heart to the capillaries. Once they get there, the gas exchange takes place between the wall of the cell and the wall of the capillary. So the only purpose of the blood is to transport everything. The only purpose of the heart is to pump the blood, okay? And then what happens after that is the blood that's used up is returned to the lungs, okay, for gas exchange. So the carbon dioxide is exhaled. In the lungs, the gas exchange takes place between the pulmonary capillaries and the alveoli. In the body, it takes place between the walls of the cells and the capillaries that are close to those cells. So if you had cardiac cells, it would be the cardiac cells and the capillaries of the heart. If you had pulmonary cells, it would be the cells of the lung and the pulmonary capillaries. So it just really depends on where that gas exchange is taking place. So there's two different exchanges. There's the exchange inside the lungs. Again, we're talking about oxygen and carbon dioxide, right? There's the exchange of oxygen and carbon dioxide at the lung level, and there's the exchange of oxygen and carbon dioxide at the cellular level, right? At the level of the cell. Now remember, this could take place in the lung, okay, without hemoglobin. You could have oxygen, leaving the alveoli and entering into the bloodstream, okay, even though there's no hemoglobin for some reason, strange reason, right? The problem is then going to be is that the blood is going to have plenty of oxygen, but because there's no hemoglobin, it can't transfer it to the cell. So, so again, just that there's a lot of issues that could occur. Okay, so for the blood vessels, which we know are artery, veins, and capillaries, there has to be an adequate pressure to push that blood through. And the structure that generates that adequate pressure, okay, is the heart, right? So the heart, by contracting or squeezing, pumping, is what generates an adequate blood pressure to push blood through the bloodstream so that it can make it to all those little capillaries. So when the blood is coming in out of here, it's high pressure. Once it starts traveling through the capillaries, okay, it becomes lower pressure, and it enters into the veins as a lower pressure going back to the heart. So high pressure because this is the heart pumping down into it. Remember, this eventually, if you swam all the way backwards, eventually you're going to wind up into the aorta, into the left ventricle, because that's the start of every artery. Every artery comes off the aorta, okay? If you would follow this back to the heart, this would wind up in the inferior and superior vena cava, empty into the right atrium, because this is bringing back the used up blood to the right side of the heart. This is taking the good blood from the left side of the heart. So this is starting on the aorta. This is ending on the inferior and superior vena cava. Okay. Now, how do we know that there's an adequate blood pressure in the body? So again, the brain is monitoring everything, right? So we had the chemoreceptors, which we said were special bundles of nerves that were looking at the level of carbon dioxide and oxygen. And then we have these terms baroreceptors. Baro are stretch receptors, which are basically looking at your blood vessels. So they're specialized nerves in the walls of your blood vessels, and they're looking how stretched they are. And they're basically saying that if there's good stretch on the blood vessels, there's good blood pressure inside, right? Because if you have a good pressure, the arteries will be nice and stretched. If their arteries are collapsing or constricting, going downward, it assumes the blood pressure is low. Now, how does the body raise and lower blood pressure? Well, one way is making the pump work harder, right? So if your blood pressure is low, it's going to tell your heart to pump faster, and not only faster, but stronger. It's going to squeeze with more force. The other thing you could do is to start to shift fluid from around the blood vessels back into the blood vessels. Remember, we're floating in fluid. Everything inside our body is floating in fluid. So if we need more fluid, okay, it will actually move fluid from that the body has circulating inside of it, but not in the blood vessels. Okay, we'll shift it back through the walls of the capillaries and bring it back into the bloodstream. That's what happens when you're dehydrated. It will also conserve fluid. So what will happen is it will increase your sense of thirst, so you'll drink. It will stop you from urinating so that you start conserving fluid. Okay, so there's a lot of different things that the body can do. It could actually choose to move blood to more vital areas like your heart, your lung, your brains, and deprive certain areas of your body with blood. So your stomach, your intestine, your skin, when you're getting into a hyperperfusion or shocky state, that gets less blood because it could last longer without it. Where your more vital organs need more fresh blood all the time, fresh oxygen, fresh sugar. So it's going to shift blood around. So it actually has the ability to kind of almost have valves that are circulating blood to where it needs to go. Okay. So that's what kind of happens. Now, we have different reasons why people could run into problems. Okay, again, we're talking, again, tonight, problems. So if you lose tone, tone is how tight the blood vessels are. So when you lose tone, you have dilation. Dilation is that a blood vessel opens up, or even any tube, because you could have bronchial dilation, right? You got bronchoconstriction, that's your lungs. Here we're talking blood vessels, so it's vaso, right? So vaso is vessel. So if you have a problem where, and we'll talk about why you have these problems in a second, but if you have a problem where the blood vessels start to increase in size, now picture miles and miles and miles of blood vessels. If they're at a certain level normally, but now they start to increase in pressure and you only have 6 liters of blood, what has to happen to the pressure, right? So if they start getting bigger and you still have that same 6 liters of blood, the pressure has to drop. If the pressure starts to drop, the flow of blood starts to decrease. So those of you that work in the plumbing trade or any trade, I guess, that, depends on fluid traveling through or even air traveling through, that if pressure starts to drop, the flow of whatever you're trying to push has to drop along with it. So why do people have this abnormal vasodilation, this abnormal increase in the size of the blood vessels? So it could be infection. You might have all heard the term sepsis, right? Sepsis is a very severe blood infection, body-wide infection. And one of the side effects of the infection is the blood vessels start to relax. You've heard of allergic reactions or anaphylaxis. So most of the times people think these are breathing problems, but they can also affect the blood vessels. People have spinal cord injuries. We said the spinal cord is how the brain sends signals to the body. And I told you that if there's a spinal cord injury, the brain can't send those signals to the body. So one of the things the brain controls through the baroreceptors we just talked about is knowing how dilated or how constricted the blood vessels are. So if that doesn't work, right, then it doesn't, then the body, the brain cannot control the blood vessels and they relax. We talked about, I think it was the last class, somebody having a vasovagal reaction when we talked about the sympathetic and the parasympathetic nervous systems, the autonomic nervous system. If you remember, it was the nervous system that works automatically. And we said it has 2 divisions, the sympathetic, the fight or flight, where it speeds things up, okay, and raises the pressure, and it has the parasympathetic, where it slows things down. And we said that sometimes people can accidentally stimulate that parasympathetic nervous system and have what's called a vasovagal reaction, where 2 things happen. It slows the heart rate and it dilates the blood vessels. Remember, this is what we're talking about now, vasodilation. So if somebody suddenly slows their heart rate down and dilates their blood vessels, the flow of blood has to decrease, right? Because you're not pumping as much and you're opening up the container, so you're dropping the pressure. And what happens is they don't perfuse their brain, they don't get enough blood and oxygen to their brain, and they faint. And we said that one of the important things we always had to do when somebody vasovagaled was to examine them for injury because they fainted and fell to the ground. So this is showing you a normal blood vessel, right? And say a normal artery. The inside of the artery where the fluid, the blood actually travels through is called the lumen, okay? So here's a normal one. Now this patient has had sudden vasodilation. So what happened? Right now, it's filled with blood. There's not an ounce of open space in the lumen. It's totally filled with blood. But now, because the diameter of the blood vessel increased, right, the blood is only filling half the lumen. So the pressure now has to drop, right? So you don't have as much fluid going through a tube. The pressure has to drop. And that's going to result in what's called hypoperfusion or low perfusion, which is another way of saying they could go into shock. Another problem that people could have is permeability. So when we were looking at this slide, if you remember the other night, I talked about the ability for things to come in and out of a blood vessel is called permeability. So how easy somebody said porous, right? Same thing. So permeability is how easy is it for something to come in and out of a blood vessel. So we know that capillaries are fairly permeable, right? That's their function, is to let things in and out. But if that permeability increases, the capillaries will start to leak out plasma. Most of the times the capillaries leak out oxygen, leak out other things, right? Sugar, but they will start leaking out plasma, right? That's the fluid portion. Now the plasma is trapped under your skin. I gave you the analogy of hives, right? Or burns, where you see fluid trapped under the skin, but a lot of other ways it could happen. So if somebody has renal failure, kidney failure, a lot of times you see they look all swollen. That's all the extra fluid because the kidneys can't process it, that are getting forced out of the blood vessels because there's just so much extra fluid, okay? So that's another loss of fluid, right? I mean, again, if you don't have a certain amount of fluid in your blood vessels, then the blood will not flow effectively. So again, sepsis is one of the issues. Believe it or not, for those of us, we pretty much live at sea level in Rockland County, right? I mean, probably the highest anybody lives in Rockland County, 300-400 feet. So let's say, I don't know, you hit it big and you take in a trip. Maybe you're not going too far. Maybe you go to Colorado. So Colorado is a mile up, okay? Well, we were not designed, right? Us, and I shouldn't say we were not designed, but we are not used to living at an altitude of a mile up. So that first week that you're in you're in Denver, you're going to feel tired. You're going to feel short of breath because your body's not used to that higher altitude. And when you're at a higher altitude, it's harder for the blood to flow. So, you know, it's harder for the oxygen to get in. So there's changes that occur. I mean, if you were to go, you know, to the Alps, it'd probably take you, you know, more than a week to acclimate to that difference in pressure and stuff like that. Okay, and there's actually emergencies when we talk about environmental emergencies. There's emergencies that people that have where it look like they can't breathe, and all it is that they travel from a lower altitude to a higher altitude too quickly, and their body did not adjust to that change. There's people who look like a stroke, and it's not really a stroke, a brain injury. Okay, but it's just a matter of all they need to do is go back to the same altitude they came from. So, you know, all they really need to do is bring them back down to a lower altitude and they will feel better, okay? So this is a bad drawing of showing you a capillary that became very permeable, and what's leaking out is supposed to be the plasma, but it's not a good slide. Okay, so we have this concept of either too much pressure in a blood vessel or too little pressure, right? So before we were talking too little pressure, now we're switching to too much pressure. So hypertension, before we had hypotension, which is too low, HYPO. Now we have hyper, HYPER. Hyper is too much, too fast, too high. So hypertension, high blood pressure, right, is the other way. So a fancy way of saying the pressure in a blood vessel, you don't have to know this, is systemic vascular resistance. In other words, what's the resistance of blood flow in a vessel, okay? But don't worry about it. So when you talk about this systemic vascular resistance, you're talking the pressure inside the blood vessels that the heart has to pump against, okay? And that's the danger when people have untreated high blood pressure. So let's say for argument's sake, right now they're saying a normal blood pressure is like 110/70. Your book probably says 120/80, but a normal blood pressure, they'd ideally like you to see is have like 110/70. Very few of us actually have that, okay, to be honest with you, unless we do a lot of exercise and eat very well. But let's say instead of having 110/70, our blood pressure is chronically 150/90. So it's chronically high. What's the consequence of that? So your heart's a pump. If the blood pressure that has to pump against is chronically high, what starts to happen to your heart? It has to work harder and it starts to struggle. Now, heart is an interesting muscle. Most muscles, when they work harder, get bigger and stronger, okay, and actually improve. But the heart is a muscle that when it starts to get thicker, it actually beats ineffectively. It squeezes ineffectively because it gets so thick that it can't actually completely squeeze and empty. So they develop something called ventricular hypertrophy or stiff ventricles, and they don't empty well. So that's the danger when somebody has high blood pressure for years and years and years. The other thing is that if you have higher blood pressure than you should in your vessels, there's always a possibility that the vessels could rupture, right? They can get an aneurysm and burst. Now, the worst manifestation, and again, we're going to talk about this later in class, of somebody having high blood pressure is called a hypertensive crisis. And that's defined that the systolic blood pressure, which should probably never be much higher than 70, 80, is actually above 110. So you have your systolic, which is the upper pressure when the heart is contracting, and you have the diastolic, which is the lower pressure when the heart is relaxed. And the more important number to tell you blood pressure issues is the lower number, because if the lower number, which is a relaxed heart, is never relaxed, it's high, it's telling you the heart is at risk, right? So, and we'll talk more about that, but you may have heard or, you know, been on a call or had a family member or a patient where they get this chronically terrible headache, they get blurred vision, they get nauseous, and you come and you assess them and you take their blood pressure and you say, oh my God, it's 200 over 110. And that's the problem, that for some reason they spike their blood pressure and they're at great risk now for bursting a blood vessel in their brain and having what's called a stroke, okay, or overtaxing their heart, okay. Now, if you remember with the lungs, we talked about tidal volume and minute volume, right? We said that the amount of breath you bring in out with each breath, okay, is called tidal volume. And when you times the tidal volume by a minute, how many breaths in a minute, you get the minute volume. So we said each breath is 500 mLs. We times it by 12 breaths per minute. We had a minute volume of air that we were moving in and out of about 6,000 mLs. So obviously we have to figure out the same thing with a heart, just to get a concept. So instead of calling it tidal volume, right, because that would be too easy, in the heart they call it stroke volume. So the stroke is that when the heart contracts, that's one stroke. So stroke volume is the amount of blood ejected by the left ventricle each time it contracts. So it's the amount of blood that, if you're beating 60 times a minute, it's the amount of blood every second, okay, when the heart contracts, right? Because you have 60 seconds in a minute. So at each second, the heart is contracting and it's pushing a certain amount of blood out of the left ventricle into the aorta. So the average stroke volume at rest is about 70 mLs. Just like you can increase your breathing if you're exercising or working hard, you can increase your stroke volume. And the body does that when it needs to circulate more blood because I don't know, you're running or you're lifting or you're scared or something like that. So we can increase that number dramatically, you know, to probably 3 times that amount if we had to. Just like you could bring in more air if you have to. Okay, so there's a, besides, now if you took this 70 mLs with each contraction and you times it by how many times a person's heart is beating per minute, you would have what's called cardiac output. And I don't know why that's not here, but cardiac output is the amount of blood that you pump out in a minute, right? So minute volume was the amount of air that you breathe in a minute in the lungs, and cardiac output is the amount of blood that you pump out in a minute. And we'll talk about that a little more in a second. Now, it's going to come up, I'm sorry. So what makes up stroke volume? So stroke volume, we said, is the amount of blood pumped by one contraction. So it's a combination of 3 things. It's a combination of the amount of blood returning to the ventricle, right? In other words, the amount of blood that the atrium is bringing down to the ventricle, because you have to have that blood sitting in the ventricle when it contracts to be able to push out. It has what is the strength of the ventricle, how well can it contract, and what is the pressure that it has to pump out into, which is really, this is, if we're saying left ventricle, this is the pressure that exists in the aorta, because that's what the left ventricle has to pump into. So that's what all makes up stroke volume, okay? Just again, conceptually, it's not gonna be test questions. So if we took the stroke volume, which was 70 mLs in an average person at rest, times it by heart rate, and here I put 100 just probably because the math was easier, but probably more likely 60, that would tell us our cardiac output, or the amount of blood that the heart pumps in 1 minute. So this is the equivalent of minute volume for the lungs, right? So the heart every minute pumps about 7,000 milliliters of blood, okay? So if this was 5, so 2 of these would be 1,000, and if we had to do so 14 of these, okay, in a minute is what it would pump. And again, we can do much more than that if we have to. Okay, now we can change these numbers and we could see how it's going to affect the amount of blood to the heart. So if the heart starts to slow down because it's having disease, it's old, and instead of doing 70 mLs, it does 35 mLs, it does half. Well, that means our cardiac output now, okay, is going to drop by half. Same thing if we start to lower our heart rate, the number is going to change. So it really depends on, you know, how you adjust this, and that's going to show you how people start to have problems with their amount of cardiac output. if the heart starts to beat too fast, okay, the ventricles don't have time to fully fill with blood. So if this number went to 200, you'd say this should go to 14, right, 1,000. But what really happens when the heart starts to beat too fast is that since the ventricles don't have time to fully fill with blood, this number starts to drop. So this equation may not change dramatically, or may change dramatically. It really depends. So when you start getting out onto the field, especially if you're functioning with paramedics, they're going to start saying, oh, the reason this patient has no blood pressure and they feel weak and dizzy and they can't catch their breath is they've gone into a SVT, a supraventricular tachycardia. Well, you know, tachycardia means a fast heart rate. They've gone into a ventricular tachycardia. Again, a tachycardia is a fast heart rate. Sometimes it goes out of control. If they've gone into atrial fibrillation, which is, you might have heard, is an abnormal atrial upper part of the heart problem. So one of the problems that happens is the heart starts beating too fast. And when it starts beating too fast, it can't completely empty. It can't, fill and empty enough, and the cardiac output drops. Okay, so when we have dysfunction of the heart, we could have a mechanical problem, we could have an electrical problem, right? So mechanical problems could be trauma to the heart. So that guy who had the piece of wood, right, if that was higher up into his chest, besides his lung, it could hit his heart, right? So he could actually have physical trauma to it. They could have problems where the sac that the heart sits in, the pericardial sac, the protective sac the heart sits inside of. We said there's problems where fluid could fill up. Remember, there is some fluid, just like there's some fluid between the lungs and the ribs. There is some fluid naturally between the sac and the heart, so that it lubricates it and you don't have pain every time your heart is contracting. But sometimes with infection or leakage of blood, like if one of these blood vessels is burst, that sac can start filling with blood and it'll actually squeeze the heart and not allow it to fill. Or somebody could actually have a heart attack where a portion of the heart is not getting the oxygen it needs and it dies, and now the heart can't contract fully, right? So that's one issue. We know that we had this pacemaker system. So sometimes that pacemaker system could get damaged and the impulses that tell the heart to beat are not coming. So there's a lot of different reasons that we'll talk about. So we're going to finish up with this right now, but putting it like all together. So from the concept of keeping somebody alive, you have to have a functioning cardiac system. Remember, the cardio side would be the blood, would be the pump, which is the heart, and would be the tubes, which are the blood vessels, the artery, veins, and capillaries. You also have to have a functioning pulmonary side, the lung side. So you have to have the airway intact, and an intact airway is called a patent, P-A-T-E-N-T, patent airway. So you have to have the tubes being unblocked, unconstricted, right, nice and open so air can come in and out. And then they have to be able to make it down into the alveoli to have gas exchange, okay? Now, never again on a test and stuff like that, but just a concept, there has to be a balance between both the ventilatory side, and again, I know ventilations, respirations, it's all kind of used interchangeably, but there has to be good function between the lungs, the pulmonary side, and the cardiovascular side, the perfusion side. So those of you that may have been around the hospital a little more and stuff, when that's not right, okay, they call it a VQ mismatch. So V stands for ventilations, Q stands for perfusion. So there's a mismatch between either the ventilatory side or the perfusion side. So just a clear way of explaining this is that somebody's heart is working perfectly. Somebody has enough blood. Somebody has enough hemoglobin. Everything's working perfectly on the perfusion side, the heart side. But yet they have a piece of food lodged in their airway. So because they have a piece of food lodged in their airway, the ventilatory side is not working. So there's not enough oxygen coming in, there's not enough carbon dioxide coming out. So they have what's called a VQ mismatch, but their problem is on the ventilatory side. Now let's do the opposite. Somebody's breathing fine, no issues whatsoever. They're getting plenty of oxygen down to their alveoli. Everything's wonderful. There's plenty of hemoglobin. Everything is good, right? So there's no problems on the lung side, but they were shot, okay? And because they were shot, they were bleeding internally. So now there's not enough blood to get that oxygen and circulate it to all parts of the body. So on this side of the mismatch, it's a perfusion side, okay? So again, just theory, but just to realize when we start putting it all together, I'm going to give you, a scenario, a description of his problem and a patient, and I'm going to say, what do we need to do for that patient? And you're going to have to be able to figure out, do I need to treat them from a ventilatory side? Do I need to treat them from a perfusion side? Or are they totally screwed up? And it's both sides, right? Everything's all screwed up. Because obviously, even if somebody's heart is working perfectly, if there's not enough oxygen coming in, because the problem's on the ventilatory side, what's going to happen as time goes on, if there's not enough oxygen coming in. Even the heart side of it is going to get affected because the heart needs oxygen to function. So, you know, again, we'll talk about it all as we go in. Okay, so we're going to stop tonight over here. So if you haven't had a chance, just read through the Pathophysiology shock chapter. I think it's chapter 7. I sent you the handouts. I guess we are slide 41 out of 66, so we're a little past halfway. So we'll finish this up tomorrow, and then we'll do some, you know, review. So if you have any good questions or anything that you want to, you know, go over in detail, we can do that tomorrow. So before I stop for the night, does anybody have any questions about what we talked about tonight? Because once we finish tomorrow night, we're done with all the how the body works and how the body's screwed up, and we're going to actual, you know, treatment type stuff or emergency type stuff or skills type stuff. So we're kind of done with that. So anybody have any questions?
What is pressuring back the heart to the heart?
What do you mean pressure back to the heart? You mean the veins bringing blood back to the heart?
No, blood pressure. The heart is giving pressure. It's getting back pressure.
So I don't know if I totally understand. So blood pressure is the pressure that exists in the blood vessels. So blood pressure is a function of two things: how much blood is being squeezed by the left ventricle into the aorta, and how constricted the walls of the blood vessels are, the arteries are. So when you're measuring blood pressure, you're measuring the pressure in the arteries, and that's a function of two things: how much and how hard the heart is pumping blood into the aorta, and how constricted the arteries are. So if the heart's pumping, you know, a lot, very hard, very fast, and pushing a lot of blood, and the blood vessels are very tight, you're going to have a good blood pressure or maybe too high of a blood pressure. And the other way is there's some kind of problem with the mechanical part, the pumping part of the heart is damaged, or there's not enough blood, or you had that sepsis that where the blood vessels are relaxed, then the pressure would be lower. So, you know, there's multiple different ways where you could either have a high blood pressure or low blood pressure. I don't know if that answered or not.
Yeah, it did. Thanks. Yeah.
What else? Any other good questions? So somebody wrote over here. I just see something popped up. Are most cases a VQ mismatch? So yeah, I mean, most emergencies are going to be, you know, one side or the other or both. I mean, let's take, I don't know, a heart attack. So, you know, a heart attack is what? A heart attack is that the blood vessels on the surface of the heart that are called coronary arteries get blocked, okay? So now the heart itself is not getting the oxygen and the sugar it needs to be able to contract. So on this side, it's going to be from the perfusion side, the Q side. They're probably breathing fine when they have a heart attack, but their heart is damaged. They can't pump well. So, you know, I mean, I wouldn't dwell on it too much, but, you know, as we do every emergency, we're going to see that it's one side or the other. And then, like I said, there's some people that are so screwed up that it's a combination of both sides. So let's see what else we have. What tissue in the body? What's tissue in the body? Okay, so tissue. Okay, so here's how the body works. The smallest thing we talk about in the body is a cell. When you have cells that have how's the right to explain this? When you have cells that do the same thing, they're called tissue, okay? Not tissue you blow your nose in, but it's just a term, tissue. So let's say cardiac cell, you have, you know, 1 million cardiac cells. That's called cardiac tissue. And then the next stage after tissue is an organ. So you have cardiac cells. When you have lots of cardiac cells, it's called cardiac tissue. And then when all that tissue serves the same purpose, it's called an organ. So it's the heart. So that's basically, you know, how it works. I know it's just it's more of just an anatomy thing than a life-saving thing. Okay. What do we have here? So chemoreceptors and baroreceptors are both monitored and controlled by the brainstem. Medulla, right. Yes. So your stretch receptors for blood vessels and your chemoreceptors for oxygen, carbon dioxide level are both in your medulla. Yep. That's the part of the brain. So these are all things that you have to monitor when you're sleeping, right? In other words, they have to work whether you're awake or asleep. So most of the stuff that has to be looked at by the body, whether you're awake or asleep, is monitored through your brainstem. What else? Anybody else have any good questions? Okay, so let me do one thing. I'm going to pause the, I'm going to pause the recording for a second.